everybody should be informed that we are recording this. So whoever is not comfortable, feel free to opt out for those who are actively participating, but I guess that's should not be an issue. I'm very, very happy to start this, and those around me know that I have been quite excited about this meeting. It's the evolving area of breathing-enhanced cardiovascular MR, and especially in the combination with oxygenation-sensitive MR, this, to me, turns out to be a very valuable tool for assessing coronary vascular function. We're very happy for the interest and for the number of participants that have already signed on, and probably more will sign on during the next minutes. The story of oxygenation-sensitive MR with breathing maneuvers for diagnosing cardiovascular disease or breathing-enhanced cardiac MR started a long time ago, and we're still on a journey, and many people have taken an active part in this journey. And actually, many of them are with us today here, so that's wonderful. Of course, we're not done yet with that journey. I mean, when are you ever done with journeys like this? There are certainly a few things we need to get done, and many here on the call or on this symposium are working on that. So before we get into the details here, I wanted to also introduce Judy Liu. Judy Liu, she will be the co-chair today. And tomorrow it will be Liz Hillier, who will also co-chair the meeting. Both of them have been very important in the previous studies that have been done on that. And so I'm very happy to have them and to still have their interest. So with that said, I will basically hand it over to Judy, who will then open the program, and will introduce the first speaker, which, funny enough, is me.
Okay, thank you so much, Matthias. You don't need any introductions, but I'm super excited to be chairing this chairing this event with you, and then Liz Hillier tomorrow. So I think without further ado, you'll be giving a very broad overview of all the history and future directions of OS-CMR. And I think everybody here will be super delighted to hear you speak.
Thank you very much. So the meeting itself will have 2 days. Today we will have an intro, then we will have speakers talking about some very recent data on oxygenation or breathing enhanced oxygenation sensitive MR, and we will also then have a brief presentation on a fully automated analysis tool. And I'm thankful for Mitchel Benovoy, the director of Circle Labs Montreal, to show us a preview of the prototype that is currently available for those who are doing research with that. And tomorrow there will be a live demo of an actual oxygenation sensitive MR scan with breathing maneuvers. So don't miss that tomorrow. It will only be a few minutes because the scan is actually pretty short. And then we will have a step-by-step explanation how the new evaluation tool can do that. And I also want to use this opportunity to thank Circle Labs for the incredible work that has been done over the recent months to develop this tool. Without such a tool, it would not be possible to analyze hundreds of images in a reasonable time frame. We have case studies then tomorrow on coronary artery disease, microvascular dysfunction, and then we will have, I'm looking forward to that, an open discussion on the use of B-MORE, so breathing enhanced myocardial oxygenation reserve, in various clinical situations. So Here we go. I will start off today with a little bit of the history. What is the rationale and what has led to basically our advances and where we are today. I want to disclose that I'm involved in the development of software, as you probably all know. I'm involved in circular cardiovascular imaging, the company that also helped us a lot actually with the evaluation side. Then I have research agreements in 2 locations in Montreal and Heidelberg with Siemens, Philips, and GE, and I also receive, the group, of course, receives research funding from various institutions. So in cardiac MR, what we basically need is anatomy, function, tissue, and coronary vascular function. So these are the important components that allow us to diagnose basically everything we need to know. And MR is, what we know is the most versatile cardiovascular imaging modality, because we cannot only visualize morphology, function, volumes, but we can also perform angiographies with MR. We can quantify flow more accurately than with any other technique. We can visualize coronary perfusion by contrast-enhanced perfusion scans. And maybe the most unique contribution, we can characterize tissue abnormalities by CMR. The problem with cardiac MR, however, is it's still perceived as too complex for many. It takes time and way too often needs gadolinium. And these are of course roadblocks, because if something is complex, people will have a certain reluctance of getting into that. If it takes time, it may not be cost efficient and time efficient. And if it needs gadolinium, there's a certain safety aspect, but it is also a cost aspect. So we need to address that. So what we have to do is very simple. We just have to speed up scanning and simplify scanning. We have to simplify and speed up the evaluation. And we have to try to get rid of contrast agents. So we can do that by automated planning and using less of so-called sequences for the scanning procedure itself. We should develop and have available, best by multiple vendors, automated analysis tools that make it easy to analyze the data. And in order to get rid of contrast agents, we have to make use of techniques such as mapping that may give us all this information without needing contrast agent. There are some very exciting developments, also a recent paper from the Oxford group, just using machine learning algorithms on mapping images without the need of contrast agents to create what looks really like late enhancement images. So if we go back to what we actually need for, and keep in mind that we need to do this, simplifying and speeding up scanning and evaluation and getting rid of contrast agents, what are the options we have? So if we look at these different areas, we have techniques, and we'll not talk about this here, which I like to call SMART, for simultaneous multi-parametric acquisition and reconstruction techniques. These techniques, like MR fingerprinting, MR multitasking, free running framework, and others, they allow us to use a single quote unquote sequence that runs over a certain time to generate data sets, MR data that allows then to reconstruct actually images as we know them, reconstruct cine images, reconstruct maps, reconstruct perfusion, late enhancement, coronary angiography, and such. And several of these techniques are already quite advanced. So it may be able in the future to cover literally anatomy, function, and tissue just with a very simple approach. That's a very important and good step. However, we're left with the need for looking at vascular function. So while you could do first pass perfusion with the other techniques, I will make a case here why first pass perfusion may in the future not be the ideal way to do that. Why is that? So when I grew up clinically, the world was pretty simple. You had coronary artery stenosis that led to coronary blood flow reduction. That created a mismatch between oxygen and supply and demand, and eventually caused ischemia. And we had coronary angiography to look at the anatomy. If we wanted to know about flow, we could use FFR, we could use PET, or first pass perfusion, CMR, all three of them now with the new chest pain guidelines, class 1 indications in certain situations. So why would we need anything more? Now, the trouble is that we have a lot of confounders, that even if you have coronary arteries that look horrible, there may be collaterals that may help overcome this, so they may not actually be that bad. And the other way around, even if you do not have coronary artery stenosis, there may be endothelial dysfunction, vasoconstriction, coronary embolism, so in a widest sense, microvascular dysfunction, also known as INOCA, ischemia with no obstructive coronary artery disease. So even if the blood flow is reduced, there may be other factors. So it's not that easy. So it would be nice to get into this level. But here we have not been very good. Imaging or realizing or verifying or excluding actually ischemia, not a surrogate marker such as blood flow or a tracer accumulation or a contrast inflow. So this is the background for breathing enhanced oxygenation sensitive MR for assessing coronary vascular function, keeping in mind that we want to ease up things, we want to make CMR faster, easier, and with not only with the scanning, but also with the evaluation. And of course, without contrast agents. What helps us here is a technique that is now well established oxygenation sensitive MRI. And this is based on the so-called Bold effect. And without now taking this too far into the physics, what it actually reflects is that the deoxygenation of hemoglobin changes the magnetic properties of its molecular environment. So a vein will look totally different from an artery if you use a sequence or MR technique that is susceptible to that effect. And these sequences are called Bold sensitive, or they can be called oxygenation sensitive. So you see, in short, you see a signal intensity drop in these in areas with a deoxygenated hemoglobin. This was used in the early 90s, and this is the landmark paper that first described the use in the brain, which is the foundation of functional MRI. Other groups, including ours, have started in the early 2000s to apply this to the heart, and this was our first clinical study. In fact, the first clinical study in patients with coronary artery disease, where we could show actually with adenosine and oxygenation sensitive MR that we could reproduce what was seen in nuclear scans, and that severe stenosis actually showed a signal intensity drop, which means a deoxygenation during adenosine. While that was good, what was not so good was the scatter that you could see. So it was clinically not necessarily that useful because there's just too much, there was too much scatter. But fast forward, we developed, and with the help of Rohan Dharmakumar, he actually proposed a sequence based on SSFP, which was much more robust with image quality than the EPI readouts here. So other groups have actually done that. And I'm not sure whether Jayant is on the call, but he has done some of the important work during his time in Oxford, where also Theo Karamitsos, who also published several papers on that, as well as Joseph Selvanayagam, who is also still active in that field, where they applied this adenosine-induced myocardial oxygenation reserve, or in short, you could call it A-MORE. And for the Italians, they can also pronounce it their way. And then using this to find out what are determinants for an abnormal response here. And they could relate that to several factors and also to late gadolinium enhancement. So this was a very important trial. In a coronary artery disease, Peter Bernhardt and his team in Germany applied this technique at 3 Tesla and compared it with the fractional flow reserve, which showed a good correlation. And at the same time, we performed similar studies in Calgary. And now I want to ask Judy to briefly talk about her study that she did at that time. Judy.
Yeah, that's great, Matthias. So in this study, we prospectively recruited 64 patients with suspected or known coronary artery disease who had the clinical indication for coronary angiography. And as you can see, we compared the A-MORE to that of FFR. And to the graph to the right, you can see that a threshold, an OS-CMR signal intensity threshold of less than 4.8 was indicative of an abnormal FFR. So this was a really good study in the right direction for us.
Yeah, thank you very much, Judy. So basically what this showed is that adenosine together with that oxygenation reserve may be good enough to really rule out highly severe coronary artery stenosis as defined by an abnormal fractional flow reserve. So the downside of all this, the only downside was that you still needed adenosine, you still needed a needle, you still needed to be a little bit concerned about arrhythmia and such. So we, at a long time ago, actually before, we made an observation that puzzled us. And the simple idea was, hey, let's just have people hold their breath for quite some time, and then because there's no oxygen, the oxygen level should drop. But what we in fact saw was that in patients, nothing happened. So there was no change of oxygenation in the myocardium during a long breath hold. And even more puzzling was that in healthy people, there was actually an increase. However, if you look up the literature of the 60s, 70s, and 80s, this is no surprise whatsoever. We actually have known since a long time, and physiologists even back in the earlier decades of the last century known that if you hold your breath, you recruit your coronary flow reserve. And the opposite, if you hyperventilate, you actually get rid of the carbon dioxide, and your oxygenation level may actually drop in the heart, and interestingly enough, also in the frontal cortex. So this is an overview of what happens. In normal breathing, our vascular tone is normal, or by definition normal. But if you hyperventilate, you induce vasoconstriction in the myocardium, and as I said, in the brain. That leads to a drop of the carbon dioxide in the blood, which leads to a drop of myocardial blood flow and blood volume, and to a drop actually of the myocardial O2, if you have a normal response, a healthy response to hyperventilation. Now the opposite happens, or a reversal happens, in a breath hold. In a breath hold, you have a fairly quickly, after a hyperventilation, you have a fairly quick recovery within 15-20 seconds. And then there is even a little overshoot, which reflects vasodilation. So this is in fact what happens during the breathing maneuver that we have now and others have tested for various applications. Normal breathing, hyperventilation, vasoconstriction, and then breath hold with vasodilation. And this difference from here, after basically from vasoconstriction to maximal vasodilation, that is basically reflective of the vascular function in the coronary territories. So we have applied that in healthy athletic volunteers, and could show that even very long breath holds even come with a net signal increase, reflecting an increased oxygenation or less deoxygenated hemoglobin. Whereas the opposite happened when we asked them to hyperventilate, where actually the signal intensity went down, indicating an increase of deoxygenated hemoglobin. So, and now then we went on, of course, then we had to compare this to adenosine. And Kady, I don't know, are you there? If so, then please unmute yourself and briefly describe what you did in that study in Calgary.
Hello. So yeah, thanks very much. So this is the study from Montreal Heart Institute. And so this is the one where somewhere in Canada. And so we took, I think, 42 healthy controls, and it's been a while. And we actually decided to combine the two components because, as we saw before, we had an individual change in hyperventilation and an individual change in with the breath hold. So we decided to combine them. So you actually start measuring from the end of hyperventilation to apnea, and then you get this much larger range, as Matthias showed. And then here we could show in the healthy controls, of course, we have this increase. And when we reach this 30-second time point, which we found is feasible for most people, we actually exceed what was observed with adenosine in a healthy population ranged up to, I think, about age 60.
Yeah. Thank you. And if you want to also comment on this one.
Yeah, of course. So all this information in humans and these pilot studies are interesting, but we always still need some actual comparisons to any gold standards. So we wanted to do another animal model. So this is in pig hearts here. So we had actually invasive MRI compatible flow probes. So that's what you see in the blue here, right on the LAD. So we could measure blood flow in the coronary artery. And of course, we had other cannulas as well in the coronary sinus, arterial lines, venous lines to really make a comprehensive analysis with invasive measures to see how the oxygenation was actually correlated with the invasive measures. And here we could also see in animals with an induced stenosis, we get this regional deficit in the corresponding territory that was, of course, related to the FFR value, which we performed in the animals, as well as the degree of stenosis and the amount of coronary blood flow increase in this vessel.
And then Kady went on to Switzerland, where she also is calling in from. She has made a wonderful career in Bern at the Inselspital, and there you have to have performed a clinical study, right?
Right, so this is one of the early clinical studies we did. So this is patients, they have a coronary artery disease. And we chose patients with staged PCI procedures. That way we could always find the coronary anatomy was already confirmed by the initial angiography, and then they still had one vessel left that was untreated. So these patients generally had a 2-vessel disease. And in the top, you see what Matthias already explained, where the healthy controls have this really strong increase. And then in the middle, you see someone who has a current LAD stenosis and a previous RCA stenosis. So we have regional deficits here, whereas this lateral wall responded pretty well. And then in the bottom, these are the patients we're also pretty interested in. So even though they might have by coronary anatomy regional territories, we see that they actually had a global drop in oxygenation that went beyond the typical angiography defined vessels.
Yeah, thank you very much, Kady, and we're looking forward to your talk in a few minutes. So we also applied this at the Montreal Institute in patients with obstructive sleep apnea and could show actually a blunted global response. So as an example for global microvascular dysfunction. But of course, at the end of the day, we also need more data on the breathing maneuver. And that's where a great study came in from Heidelberg, and Marco Ochs, the first author, is also here. So Marco, if you could also briefly explain what we did there and what you found.
Yeah, thanks, Matthias, and hello to everybody. In this study, we evaluated a potential application of the hyperventilation breath hold maneuver as we studied patients, all-comer patients, with the question of ischemia to our cardiac imaging unit. And we compared this protocol, this needle-free protocol, with the standard adenosine perfusion and against invasive measurements. And our idea was to replace adenosine by this hyperventilation breath hold maneuver, and to get rid of the contrast agent we usually need for the perfusion. We applied a strain method, the F-sync. And what we found was a very high specificity and sensitivity to invasive measurements to detect ischemia. And it was non-inferior, this needle-free method, to the standard contrast perfusion methods. So we are very positive about the results and potential application in the future in the clinic. And just recently it was published by Sebastian Kelle from Berlin and Grigorios Korosoglu and Henning Steen about the prognostic relevance also of F-senk during a perfusion. There's upcoming data that shows us the value in daily clinic routine.
Thank you very much. And importantly, this test only took 64 seconds. So it fulfills certainly one of the important criteria, because it is also fast and it doesn't need a contrast agent. So the work in Heidelberg also included a lot of another very important study in patients with acute coronary syndrome. And one study showed that acute coronary syndrome comes with wall motion abnormalities that are getting worse with adenosine. But of course, the question also was what happens with just with the breathing maneuver. And Deborah Siri, who is now in Heidelberg at the University Hospital, she performed this study. And Deborah, I think you're also on. If you could also just unmute yourself and ideally put on the video and let us know what you did with that study.
Yes, hello, thank you. Yes, I just give you a very brief overview on our work. So we recruited 108 patients presenting with acute chest pain in our emergency department, and then performed the F-senk CMR together with the hyperventilation breathing maneuver. After manual contouring, we then aimed to triage the patients according to our suspected underlying disease. And the main goal was to identify those patients with acute coronary syndrome due to obstructive coronary artery disease. And when we compared our findings to the patient's final clinical diagnosis, we can see in the graph on the left that the F-senk images at rest were comparable to looking at serial troponin T measurements. However, adding the hyperventilation images significantly improved our diagnostic performance, especially regarding positive predictive value. And then we also looked at the quantifiable markers, such as the number of dysfunctional segments with a strain above -10. And you can see in the ROC curves that the area under the curves were much higher than compared to standard parameters such as ECG or ejection fraction, or even the serial troponin T. So yeah, I think it's very promising to combine such sensitive cardiac imaging methods together with the non-invasive stress tests in form of the hyperventilation breathing maneuver.
Thank you very much, Deborah. And Deborah has a very important exam coming up, so good luck for that, and best wishes to Heidelberg. So another important piece of data also came this year, actually from China, and the group around Kady and Zhigang, they applied the breathing maneuvers with oxygenation-sensitive MR in patients with acute myocardial infarction or after acute myocardial infarction. And what they found is that basically they confirmed what we had shown before in several studies and in by several groups, is that compared to the simple breath hold, a breath hold after hyperventilation basically uses the entire range of the vasoactive or the vasoactivity induced by the breathing maneuver. And they also could show that when they compared it with adenosine, that they also had comparable results of the myocardial oxygenation when they compared just the hyperventilation, and they just used a 10-second breath hold. So it wasn't even the 15, 20, 30 seconds that we recommend, because there's actually an additional level. But even with 10 seconds, they were able to show that it was comparable with adenosine in that population. And what also another very important outcome of that study was that it was not only feasible, but also safe in patients after recent acute myocardial infarction. So bottom line here is we have already very important validating data sets in animals. There was Kady Fischer's and Dominic Günsch's work. I also want to mention him. He's also in Bern, in Switzerland now. In healthy volunteers, in patients with global microvascular dysfunction, such as sleep apnea in patients with regional myocardial dysfunction, coronary vascular dysfunction, as in acute myocardial infarction, coronary artery disease with stable disease, and in acute coronary syndrome. So we have a lot of important data points, and they all point into the same direction. So how can we clinically apply that? And this is here from a review recently published by Liz Hillier. We will use that as maps, because maps are able to give a lot of complex information on regional abnormalities much better than any numbers could do. And here's such an example of when compared to healthy people, how the signal intensity here in a color-coded map with blue being low, showing actually the deoxygenation during hyperventilation in patients with coronary artery disease, where it's more low focal change as compared to someone with severe diffuse disease, where the vascular function is basically down over the entire period. And we will also later hear about, and I will not go too deep here, into the tools that would actually allow to analyze that in a short period of time. Now, in preparation of something you will hear later today, I also want to mention that the breathing maneuvers not only lead to a change of the oxygenation, and not only, as shown by Marco Ox and his team, and also by De Boaziri, to a change of function when analyzed by strain, but also leads to a change of the breathing, of the heart rate. So if you hyperventilate, normal people have an increase of the heart rate, whereas patients do not. And this marker alone, as we've published 2 years ago here in this paper in Scientific Reports, this alone in this retrospective study actually was able to demonstrate that the heart rate response may allow to differentiate patients from healthy controls, although not between heart disease, of course, but you can discriminate patient from non-patient. And this was very important because this could be used as an additional marker derived from the same study. So you can use the same MR scan to check for oxygenation, strain, because you can use the cine images from the oxygenation sensitive MR for strain analysis, and the heart rate response. So the to-do list that we have now is we need standardized sequences and protocols. We need some more clinical studies in other populations. We need to get more sites on board that actually allow the transition to clinical application. We need evaluation tools available. And of course, the FDA has to put their stamp on it. But given the current evidence, I have no doubt that this will, of course, happen. So with that said, I want to first thank you all, and I'm really very happy. We have close to 100 participants here. It's the largest CMR meeting I have, I think, attended in months. So I'm very grateful for the interest, and it's also showing how important this field, or reflecting that. So back to you, Judy.
Yeah, absolutely. That was a fantastic, very excellent high-level overview of everything related to OS-CMR and what's to come. I want to let the audience know that for the rest of the day and tomorrow, the chat box is open. So feel free to enter your questions, and we'll be able to address them at the end with the speaker. And I think after Matthias today, we don't have enough time, but save all your questions too for tomorrow for our open discussion led by Dr. Liz Hillier as well. So without further ado, you has heard about Dr. Kady Fischer already. So she's based out of the University Hospital in Bern. She's an assistant professor in Bern and is a scientist also in the Department of Cardiovascular Anesthesia. And her next talk today is going to be about OS-CMR with breathing maneuvers in the population of heart failure with preserved ejection fraction.
Okay, thanks. I assume everyone can see my screen, so I'll just keep going. Let me know if there's any issues. So as Judy explained, this will be in the group in HFpEF. So this data will be in what we've called the BEEF study. And yeah, here you go. So we don't have any conflicts of interest relative to this. And then this study was funded mostly by local grants and then some money from the Swiss National Scientific Funds. So what is HFpEF? This is probably one of the biggest questions there is so far. So we know it's often related to higher rates of diastolic dysfunction, aging, found in females, associated with microvascular disease, and so many things. One other problem is it's often associated with many comorbidities. So there's always the discussion of where the comorbidities end versus the HFpEF. And for more general mortality, people have already found that for just clinical outcomes and cardiac outcomes, that mortality and morbidity are almost the same as HFrEF. We also focus on anesthesia risk factors as well. And we can see that HFpEF does come with higher in-hospital mortality after surgery, and many of the comorbidities associated with HFpEF are related with worse mortality, longer ICU stays, etc. So one of the problems is, of course, it's underdiagnosed. It's expected to occur in at least 50% of heart failure patients. There's many different changing guidelines. Even throughout this study, I think there's 4 or 5 different consensus statements or guidelines. And even when there are guidelines, it's still a really heterogeneous group, and there's many different phenotypes. So, I mean, here's a nice paper that was in JACC Imaging last year. And you can see this is what their suggested phenotypes are. It basically covers almost everything. And there's different ways you can go about doing this, but we wanted to focus on a few of these components where we could apply MRI. So as Matthias talked about before, where we have this comprehensive approach. So we can look at mapping and strain and oxygenation. So this is our BEEF study. So the point of our BEEF study was to see if we could use this comprehensive CMR exam to really characterize myocardial abnormalities in HFpEF and see if we can look into this pathophysiological cycle at all. So this was with patients recruited in both Montreal and Bern. And it was just a single contrast enhanced CMR exam. And so for the guidelines of this one, this was based on the 2015 ESC guidelines for HFpEF. So it was mostly focused on diastolic dysfunction inclusion, BMP, and of course, any diagnosis of heart failure. And the majority of exclusion were just MRI exclusions. So the main goal is, of course, to look at myocardial oxygenation. That's the point of our talk today, but also to correlate it with myocardial tissue features and structural features. So eventually we ended up with 29 patients. And we have to say that most of this recruitment ended in 2017. So only 6 patients actually had a real HFpEF diagnosis at the time of enrollment. And especially at our site, we've gotten to notice that many more got this diagnosis afterwards. But it was just a point to say that HFpEF still wasn't really a clear diagnosis, despite the people meeting these criteria. And we also have a healthy control group of about 12 healthy controls over than 50 to create some cutoff values. So for this report, we report the global values, but we also want to see if people had regional abnormalities versus global abnormalities, because that's the advantage of these quantitative parametric mapping techniques. So I'm not going to go too much into this, but the point is just to show that in HFpEF, it often has a fairly equal or even dominated by females. So we have a 45% ratio. And in comparison to many other cardiovascular diseases, you know, that are often quite more shifted to the male proportions, this is what we see. And also, we did limit the amount of people with coronary artery disease beforehand, so we didn't have too many. But it should be noted that all the females had no history of coronary artery disease, and technically only 1 patient had known current coronary artery disease. The rest all had reperfusion. So I don't know if you guys have looked too much at the HFpEF score, which I call the HFpEF score, which isn't the real name, but it's easier to say. So this was published in 2018. And you can see most of patients have this intermediate or high risk score. So this is one of the newer scores that we like to look at for HFpEF. And it's really simple. It's just a score category. And if you hit 2 to 5, that's an intermediate risk of HFpEF. And if you're above 5, that's high risk. So we applied this retrospectively, of course, because we couldn't use it to recruit our patients. But it includes, typical factors such as hypertension, history of atrial fibrillation, pulmonary hypertension, the elderly, and diastolic dysfunction. So our technicians, they like to call HFpEF Kartoffelherz. So that means potato hearts in English. And why is this weird? So we see with our healthy controls, this is kind of a normal heart. We have it function well. And of course, with like HFrEF or CAD, you can often find it looks quite abnormal. But the HFpEF, maybe if you're just focusing on ejection fraction, it would be normal because that's the whole point. It's about 50%. But these patients, a typical feature is often these small little round hearts. And so it ends up having small stroke volume index. They probably have variable heart rates or high heart rate to compensate for this low stroke volume. And it ends up leading to a quite small cardiac index. And then this is associated with the heart failure symptoms. And so if we looked at functional analysis, I want to go over this quick. You see that we typically would see large atria because of the higher filling pressures, while ejection fraction is normal. And as I explained before, this leads to small volumes and small cardiac index. So we could do all that with echo. Why would we want to go to, as we talked about before, the expensive machine with CMR? But of course, we want CMR to really assess the puzzle of HFpEF, so to really apply many different features, especially oxygenation, to really look at this disease. So there's been quite a few schemata published in the last couple of years about what is HFpEF, but maybe unlike typical disorders that seem to follow a linear pattern, most people are on this belief process that HFpEF is really this cycle where it's just repeated micro-injury, just keeps adding on top of each other. So with inflammation leading to microvascular ischemia, which then leads to fibrosis, which further just adds on. So how could we use CMR to do this? Of course, if we considered our end-all features systolic and diastolic function, you can use mapping, T2, T1 mapping to look at edema of inflammation, use the other mappings to look at fibrosis, and we want to use a myocardial oxygenation as a marker of vascular dysfunction. So I think most of us know this, but yeah, myocardial ischemia is when blood and oxygen is applied to the heart, can't meet the demand of the oxygen, can't meet the oxygen demand of the heart tissue. So it's a bit different than the perfusion. And we're mostly focusing going beyond the epicardial vessels down towards microvasculature. And a few papers have already started looking at the invasive measures of microvascular disease in HFpEF. So one of the gold standards for microvascular measurements is IMR, or thermodilution in the cath lab. So then they'll actually try and quantify the amount of index of microvascular resistance. And these people here show that HFpEF patients do have a higher, so a worse microvascular resistance. Here's a brand new paper, I think from this summer, and they show dark blue, just so you see dark blue is known diseases, whereas light middle blue is these patients had this disease, but it was unknown. So what they found is microvascular dysfunction is often quite prevalent, but was almost totally unknown in these HFpEF patients until they came in this study. So it's just really showing this is an unknown feature, although it's common. And when we look at this ischemia cascade, how could we look at this? So we like to focus on the deoxygenation. So looking at the imbalance between myocardial oxygen supply and demand. And as Matthias talked about, we try and use metabolic regulation of coronary blood flow. And of course, feedback markers such as high CO2, low oxygen, adenosine are associated with the vasodilation. And then these are known to have the biggest impact in the microvascules as well, which control the majority of the blood flow. So of course, in the study, we're going to use the bold imaging with this hyperventilation breath hold maneuver. So this is our results of the myocardial oxygenation. So you can see in our older healthy control group, we had about a mean of 9%, which is 1 or 2% lower than younger controls, but still mostly within the range. Whereas you can see in our HFpEF global group, we have quite a significantly lower measurement. And on the right side of this graph, we see the difference based on this coronary artery disease status. And we can see that this had actually really no significant impact on the bold, of course, small cohort, and that most of the worst patients actually seem to have no history of any CAD. And so what we want to do is we want to go beyond just the global measurements. We're really interested in looking at the regional response. So we could find that almost all the patients had at least some regional deficit with this oxygenation imaging. And over 83% actually showed a regional actual drop, so deoxygenation. And then 33% had a global deoxygenation, so where the whole myocardium showed a drop in oxygenation signal. And when we look at the territories here, this is our typical AHA plot. And this represents the number of patients who showed abnormalities in this segment. So remember, we only have one person with KHK, so we don't think there's too much regional impact. But we can see, of course, the more apical you go, so in the middle row, there's a higher relation of myocardial oxygenation abnormalities, and we see a bit more in the septum as well. So then when we look at edema, so I don't know if I mentioned inclusion, but we make sure to not take anyone who'd had any recent cardiac events or any recent cardiac procedures. And we could see that edema is actually quite prevalent in these groups as well. especially with maybe this global diffuse patterns. And then ECV, so this is probably one of the most classical MR features of HFpEF so far. It's one of the main predictors of mortality and hospitalization in this group. And then we can see, of course, as a marker of diffuse fibrosis, we see this quite often as well in these patients. However, it should be noted, it actually isn't as high as we see with the other feature, myocardial oxygenation. So ECV is probably one of the later steps as we saw, especially once you get to the global ECV. So then, of course, because we wanted to do regional assessments, one of our main things was to do linear assessments to see how the regions were associated, so not just focusing on the global heart. And we found that this myocardial oxygenation was actually quite strongly linked to increasing T2. And then the next step is, so we see this, but can we relate this to the ventricular function? So yeah, I think we'll talk about this later, but we mostly focus on myocardial strain because, as we said, ejection fraction isn't too interesting in this cohort. It's one measure, and strain is the deformation between the relaxed and contracted states. And probably one of the most common measures here is this peak strain, which represents the maximal deformation. So it's a systolic marker mostly. And why we like strain is because then again, unlike ejection fraction, volumes, index, we can really quantify it regionally and get the measurement per segment, and also look at mechanical dispersion and other quantifiable markers of function. And of course, go beyond systole, let's look at diastole, and we get our diastolic strain rates here as well. So why do we want to look at diastolic function? So diastolic function is like one of the key characteristics of this cohort, and it's ventricular relaxation. So most times when you think of original risk factors, people really focus on coronary artery disease and reduced left ejection fraction, but diastolic dysfunction actually has its own risk factors. And it's obviously associated with poor filling. It can lead to pulmonary congestion. It's, as we talked about, it's related with a bunch of other risk factors as well. And the problem is you might actually miss these in high risk patients because you're just focused on this left ventricular ejection fraction. And so for the study, we based our inclusion, of course, on the gold standards of diastolic dysfunction measures, which is through echo and mitral inflow. But we wanted to look at our tissue tracking, and we can see here we have our E and A waves. And so I'm just going to go through this fast so we can compare it. And so if you're not so used to the diastolic functions yet, we have our early active relaxation phase, which we're going to focus on with the myocardial oxygenation, because this actually requires energy, and this is a high workload procedure. So this is when the ventricles actually actively relax to allow the blood in. And then we have the second component, which is what we would call the passive phase. So this is when the atria contract, and that sends in the blood to the ventricle in the second phase. So here you can see with our 40 flow image that we actually have two inflows of blood into the ventricle. And then in this patient, it's one of our HFpEF patients. So you might know with the late phase, we actually have a higher amount of blood flow. And then this is a typical feature of early phases of diastolic dysfunction, where because the ventricles are so stiff, we actually need a greater contribution by the atria. So when we look at our measurements, we see that 90% had abnormal diastolic strain rates. And this is what we expected as an inclusion procedure. However, if you notice when we do it regionally, we see again, it's all mostly in the septum that has the highest amount of abnormality. And that this early diastolic strain rate was related to the myocardial oxygenation deficits that we see with this CO2 challenge. And of course, it was also linked to a high amount of ECV. And then I'll just finish with this last component, but we looked at also systolic measures as well, because it's one of the things with HFpEF that when EF is above 50, is there any systolic dysfunction? But if we use strain, so deformation, we actually see that globally 47% of these patients have abnormal circumferential strain, so kind of in our short axis view, and 60% have abnormal longitudinal strain. And then when we apply this to regions, we see that almost all patients have some sort of regional systolic deficits. And again, this occurs mostly in the septum. So we're not the first people to show this, of course. People with echo have shown pretty similar proportions of people having abnormal strain, indicating poor systolic function despite preserved ejection fraction. And then this has also been shown to be a prognostic marker in HFpEF. And so there's also now different components saying, do these two markers contribute to ejection fraction at different stages in HFpEF? And eventually when your strain drops, you have other mechanisms, including thicker walls and lower end diastolic volume. So we want to look at these thicker walls as this compensation mechanism, because we see that, of course, the increasing wall thickness is associated with the decreasing systolic function measures. And so in our results, we are seeing that this relates to the proposed schema. But more importantly, with the OS, we see that there's reduced myocardial oxygenation in patients who have this higher septal wall thickness. So we know that the septum is an earlier feature of remodeling from ventricular pressure overload. Edema is also linked to this thicker wall, which can impact the oxygenation. We see this circle between the three features. And then also in other cohorts, that thicker septal walls are knowingly associated with perfusion deficits, and it's associated with compression of the epicardial vessels and microvessels as well, especially in the systolic phase. So this is the overall prevalence of abnormality. So if we looked at maybe our traditional CMR markers, such as cardiac index, LGE, EF, in this cohort, you would see we don't see too many abnormalities, and that was often the problem with HFpEF, is they weren't maybe classically diagnosed. But when we move to our more quantitative measures, we can see that most of these patients have a pretty abnormal peak circumferential strain, and myocardial oxygenation is also right at the top of this cohort when we're defining them. So of course, there's limitations with this type of study. One of them is, of course, defining who is HFpEF and who isn't. And these patients are often quite complex, and we're dealing with small sample size. We haven't been able to look at any outcome. And we still want to be careful in this cohort with saying it is microvascular disease, because we don't have a gold standard or comparison to microvascular disease, but it is dysfunction in the absence of macrovascular disease, we can say. And then, so just as a summary for this, we can say that the vascular dysfunction, as measured by attenuated myocardial oxygenation, is associated with, again, myocardial edema, a thicker septum, and diastolic dysfunction. And then this comprehensive exam could allow for, comprehensive phenotyping imaging session of HFpEF. And then I just want to spend 3 minutes explaining why we actually want to apply this to anesthesia now. So I'm in the Department of Cardiovascular Anesthesia. And so we want to actually use these advanced imaging techniques to look at how procedures during anesthesia would actually impact the heart as well. And we want to apply these imaging modalities, especially echo and CMR. And CO2, so in this diagnostic approach, we use CO2 really in the diagnostic setting, as we've explained. But of course, CO2 changes, of course, happen many times during anesthesia. They basically make their own breathing maneuvers continuously during surgery, like we do in the MRI. And there's also other stimuli that can impact the vessels as well. So this is a very nice stock photo of anesthesia, but we always want to say there's tons of cardiac stimuli during anesthesia, because this is actually what anesthesia looks like. So in addition to many changes in CO2 that occur forced, so not on the voluntary, the patient normally, we have to deal with like blood loss, fluid control, and many surgical procedures as well. And the reason we want to look at OS is because we are looking at a new thing, well, not new, but known, but myocardial ischemia and non-cardiac surgery. So this is for patients who are having horizon troponins, who are having cardiac issues after surgery. And especially this means, we obviously know people are older, there's much more cardiovascular diseases, just the impact of general anesthesia is putting these patients at risk. And we think because it's not known ahead of time, this might be a result of microvascular disease. And it's already known diastolic dysfunction leads to postoperative heart failure. And how this whole correlates is in our BEEF study, we actually find, of course, that diastolic function was associated with the CO2-induced myocardial deoxygenation in HFpEF. And I'm just going to skip this quick, but it's all about these patients are quite difficult to manage. You have to deal with all these pressure and volume losses. And of course, if you give fluid, you put the patient at risk for anemia. You also have to deal with the abnormal RV dysfunction. And so they're actually very difficult patients to deal with in anesthesia. And that's why we want to especially look at the impact of ischemia, because most times when patients will have poor function, the first thought is to give inotropes or stuff to improve contraction. But the point is we actually want to improve diastolic function, allow more filling, and that will increase the function and also will help us avoid ischemia. So this is how the BEEF kind of correlates to the anesthesia more. And this is a study from this BEEF patient. So I just wanted to give one case study. So this is a lady who is 55 when she first came in, NIHA 2, and she had some maybe typical risk factors, some AFib and dyslipidemia. Of course, when she came to echo, it was 60%, diastolic dysfunction grade 2, and no relevant valve disease, hypertension, or CAD in the angio or clinical stress MR. So, I mean, she was 55, so for them to actually put her to both of these meant she probably had some symptoms. And that was in 2013. So, but she wasn't ever diagnosed with anything, always just sent home. We just saw her in the anesthesia Sprechstunde outpatient clinic for a different type of surgery. And if we had the HFpEF score back when she came, she would already have met a pretty high probability of having HFpEF at about 70%. And then when she came back in 2015, so this is when we enrolled her into our study, she would have had a 90% chance of HFpEF based on this score. And so when we scanned her, we could see, of course, she had quite large atria. Her cardiac index was a bit low. Even though she had normal GLS and GCS globally, she had septal deficits. And then this is her imaging. So sorry, it's not too nice a picture of OS-CMR, but we saw that she had a pretty global deficit of oxygenation, but especially in the septum. She had very high T2 everywhere and also quite a high ECV. So again, this is a patient that had no HFpEF diagnosis or anything. So after the study, she had to eventually go for multiple cardioversions. She was diagnosed with HFpEF 2 years after the study, independent of our results. And at one point, I think after 3 years, she ended up having to be submitted to the emergency with EF at 20%. And eventually she had valve disorders and everything fixed. And then after they did all these procedures, she went back up to this HFpEF preserved EF again. So of course, it's not an outcome study, but it's just to show like these MRI features about 2 to 3 years before she really started getting worse, could already depict she was one of the worst patients in our study for all these parametric quantitative measurements. And oh, sorry, this is her anesthesia as well, just to explain how it's difficult. So in anesthesia, you want a nice blood pressure that's straight, you want nice heart rate that's straight. And they call this mountain and valley anesthesia. So she just goes up and down, crashing a little, maybe on bypass. So it's a really difficult patient. And the problem is these will often be non-cardiac surgery. So it's just something to monitor. And why do we like HFpEF? So we've actually included this score even in our risk evaluation forms that now go through all patients. So it is important. And also our clinic, the cardiology side, has now introduced a HFpEF specific clinic for the cardiology. So now it's not combined with all these HFrEF patients and other ones. There's actually a clinic completely devoted to them. And so our take-home message is this study adds to the understanding of the pathophysiology of HFpEF, and we try and implement the state-of-the-art imaging markers with novel techniques. And of course, we want to underscore the importance of microvascular dysfunction and also raise evidence about the role of myocardial edema in this cohort. And then, of course, this is thanks to all the people in Bern and Montreal who actually ran the study.
Well, thank you very much, Kady, for especially also for this very interesting case study of that patient. So the fact that HFpEF is studied so intensely right now reflects that we do not understand yet enough, but microvascular function probably plays a key role. And that also relates to the fact that we have more women than men with that disorder, and microvascular dysfunction in postmenopausal women is an important research topic that also Judy has been following. But before I ask Judy for what she did in Los Angeles, Kady, a question to you. The observation is very interesting and matches actually what we also sometimes see in T1 maps of patients with heart failure of whatever origin, that it often seems to be worse in the septum, and you saw that too. So one might speculate, and this is how I try to say, okay, maybe it's in advanced heart failure where you also have a right ventricular component, then the mechanical stress on the septum is just twofold because you have the left ventricle and the right ventricle both pulling at the septum. But of course, this is just a hypothesis so far. Have you thought about that, or have you any ideas why we have more trouble in these patients with oxygenation, but also with other factors like strain in the septum?
Mm-hmm. So, well, one of the things that in reports is we did at least some RV-EF and RV strain, and we already found that again, half this cohort did have some RV dysfunction. And also the cardiologist who runs the HFpEF clinic here, that is his also favorite, what am I trying to say? That's what he thinks as well, that there's so much RV dysfunction in HFpEF and it's also not known about. And so, yeah, I think like, first of all, the septum is always seems to be one of the first that you have the remodeling with as well. And it has to be probably both the right and the left side, because again, HFpEF is often associated with pulmonary hypertension. And then eventually we just get this feedback loop that comes into the right ventricle as well.
Yeah. Yeah, no, very interesting. And also the so-called mid-wall sign that we see in late gadolinium enhancement also is preferably found in the septum. So I think there is definitely, and then there's so-called RV insertion fibrosis. So I think it's reflecting that that specific problem of the septum. But then Judy, you did or initiated some work, and I know there's more going on, but maybe you can briefly comment on how this interest in oxygenation in patients with INOCA, microvascular function, how you think this will evolve.
Yeah, absolutely. Also, as the co-chair, so we just got a question from Sheldon Madger to Kady. And so before I go into so how much do you think that the LV diastolic pressure is affecting perfusion changes in the wall and the HFpEF? So I think it's in follow-up to Matthias's previous question there about the septum and the wall stress. And so maybe Kady can answer that and what her thoughts are.
So like right now, I have to say we don't have like invasive measurements of any of the LV-RV pressures, which would actually be nice if we could cooperate with the cath lab to get those patients. But I think it's, yeah, as we discussed before, we have both factors. So we have like this pressure that's onto the wall from basically the inside of the ventricle. So when you're, especially with systole, you're having extra compression factors kind of coming from both sides too. So we think this has an impact. And then of course, the long-term perfusion changes, just creating lots of stress and edema and fibrosis into the ventricle for the long-term development. And then for the other part, I see the beta blocker question. So we've done a few studies with coronary artery disease and these ones, and we haven't seen any statistical results for beta blockers and everything at the moment. But I think Matthias answered that one.
Yeah, no, I agree with that. And your question, Sheldon, is a very important one. And I think it even relates to, Kady, you also mentioned edema. I also can imagine that patients with heart failure, HFpEF, and Kady showed the relationship between oxygenation and edema also leads in these patients to some mild reversible injury, which in the myocardium then actually is materializing itself as edema. But edema does two very important things. One, it increases the mass a little bit. That would cause a hypertrophy. And more importantly, it reduces, of course, compliance. But if you have a reduced compliance, your pressures will automatically increase, then making it more likely that there will be some future injury. So that's as edema. So that, to me, would be a good explanation why patients with HFpEF basically run in and out of their heart failure, of course, with a normal ejection fraction, because edema does not necessarily reduce ejection fraction. Yeah. Okay, I think in the interest of time, we'll have to move on. And I would like to ask now Kate Lindsay, and thanks again, Kady, for joining in. And I know you're going to an event later, so I hope to see you back tomorrow, otherwise sometime soon. So I want to ask Kate Lindsay from our team here in Montreal. Kate is a master's student, and she has worked on basically our normal values database. And she has also now performed a study, or is about to finish a study, on the impact of age, sex, and body surface area on B-MORE. So Kate, the floor is yours. Can you share a screen?
Hi, everyone. I'll go ahead and share my screen. Can everyone see the full screen slides?
Yeah. And for those who came in a bit later, so B-MORE stands for breathing-induced myocardial oxygenation reserve. So B stands for the breathing, whereas there's A more with adenosine-induced, but MORE stands for myocardial oxygenation reserve. So Kate, sorry for that. Go.
Hi, everyone. So like Matthias said, my name is Kate, and I'm a master's student who works with the group here at the MUHC. And today I'll specifically be talking about the impact of age sex, and BSA on B-MORE. The main question that I'd like everyone to focus on throughout my talk is how do basic demographic characteristics like age, sex, or BSA affect microvascular function? It's known that age, sex, and body composition all affect vascular health. These parameters are used in several different risk scores to obtain risk of cardiovascular or other diseases, and have all been used in several large-scale studies over the years. But the extent of this effect on vascular health in otherwise healthy individuals, that being said, individuals who have no comorbidities or other conditions, remains unclear and is still debated. It's known that aging induces vascular stiffening. Even in individuals who have no other comorbidities, there's still an effect of age on the heart and the vasculature. On the left-hand side, you'll see the image of the heart with a few examples of how the left ventricle and the aorta changes with age. In the aorta, increased growth factors induce increased collagen and decreased levels of elastin. This decreases the elasticity of the aorta, which can then lead to consequences like an increased systolic blood pressure with a decreased diastolic blood pressure. This result can lead to a mismatch in the oxygen demand and the oxygen provided. This has further consequences like a potential for ischemia and other molecular factors which can increase the chance of hypertrophy and fibrosis in the heart. And on the right-hand side, you'll see a diagram depicting a young, healthy vessel on the left compared to an aged, hypertensive one on the right. On the right-hand side, a stiffer, more narrow vessel can lead to endothelial dysfunction through processes like vascular remodeling, overall increasing the stiffness, and compounds that induce inflammation or calcification. Vascular pathologies also differ by sex. It's known that male sex is a risk factor for many cardiac diseases. But it's also true that female sex has unique risk factors. Pregnancy, oral contraceptive therapy, or specific disorders that occur during the pregnancy can all affect the female vascular system uniquely. These can also compound with the traditional risk factors, age, depression, diabetes, or hypertension, to name a few, to create a unique pathophysiology of heart disease and subclinical disease as well. On the right-hand side, you'll see some examples of how heart disease occurs in women. This can also lead to women being underrepresented in cardiac literature. Thirdly, it's known that excess body fat can lead to vascular dysfunction. By this, I mean excess adipose tissue. In the central figure, you'll see two examples, the first being a normal level of adipocytes and adequate vascular function, followed by excess adipocytes, or known as fat cells, and the process that occurs there. These excess adipocytes can enter positive feedback loops to produce more levels of things like cytokine, immune cells, or free radicals, which encourage vascular dysfunction through more narrowing and stiffening. On the right-hand side here, there's an example of the effects that excess adipose tissue has on the heart. It can even lead to right ventricle failure or left ventricular failure. So overall, we can say that cerebral health and cardiovascular health, the brain and the heart linked by the vascular system, are both affected by non-modifiable factors like the person's age and their sex, as well as what are sort of called difficult to modify factors like BMI, body composition. To look at this, we're of course using OS-CMR. We've seen that vascular response is reduced in individuals with cardiac risk factors. This was shown through a blunted B-MORE in patients like those with CAD, as well as those who were not patients with CAD, but just had clinical risk factors. This was another study by Judy Liu, great work, Judy, showing how people in a risk factor group with type 2 diabetes, smoking, dyslipidemia, family history, or hypertension had a blunted B-MORE. This blunted B-MORE was shown globally as well as specifically in the subendocardium. So this shows us here that there's subclinical changes that occur in the vasculature, even if the individual doesn't have a diagnosed cardiac pathophysiology. So our overall objective today is to understand the impact of age, sex, and body composition on microvascular function in the general healthy population. So how did we look at this? To do this, I looked at individuals who took part in 6 studies. The 6 OS-CMR studies were spread across 2 sites, the MUHC in Montreal and the Inselspital hospital in Bern, Switzerland. From these studies, we were able to pool together a group of 109 healthy individuals who had participated in these studies. These individuals had no previous history of any cardiac conditions and no identified risk factors at the time. They all underwent a 3 Tesla Siemens CMR using the same breathing maneuver protocol that Matthias described. They were recruited prospectively into their studies, and I analyzed the results retrospectively. The factors that I looked at from study records were BMI, BSA, height, sex, heart rate, weight, blood pressure, and age. I looked at the impact that these factors had on the microvascular response seen through B-MORE using ANOVAs, t-tests, and regressions. One of the first things that we found was that the B-MORE differed by site, but specifically in older adults. On the left-hand figure, you'll see the average B-MORE in the MUHC site and the Bern site. Interestingly, there was a significant impact of age on the individuals from Montreal, but this impact was lost when we looked at the individuals from Bern. Specifically, in the Montreal site, age caused the B-MORE to reduce over time. So those who were older had significantly lower B-MORE. But we didn't see the same result in Bern, as you can see from the chart on the right. I was able to calculate a measure of Framingham risk using the individual's age, sex, BMI, and blood pressure. The group that scored the lowest on this score did show the highest B-MORE, but this wasn't statistically significant. Another factor that we saw impacted the B-MORE was height. The taller the participants, on average, had taller B-MORE, and this was statistically significant in the regression that you see here. The 2 sexes also differed in their response to B-MORE. So as you can see in this graph, men actually had overall a higher B-MORE response. This was seen not only in the 2 sites individually, but also the results overall. This was very interesting to me, given what we know about male sex being a cardiac risk factor in many diseases, but also how we know that females are often underrepresented in cases of microvascular dysfunction. Interestingly, we found that B-MORE actually increased with increasing BSA. Though this result, as you can see in this graph, there's a huge spread of the data and the data points are very variable. I also constructed a multivariate analysis with the dependent variable being the B-MORE and the independent variables being the factors age, sex, heart rate, BMI, BSA, and blood pressure. This table depicts the results of both our unadjusted linear regression models and the adjusted multiple variate model. We saw that in the adjusted model, the multivariate analysis, BMI and BSA were predictive of the B-MORE. So what can we make of all of these varied results? I believe one of the factors that we can discuss here is the effect of age. Age affects microvascular function, and we saw this in our assessment of B-MORE in the Montreal cohort, but it might be confounded by other lifestyle risk factors. Exercise level, socioeconomic factors like stress, or even the person's environment, like pollution and other lifestyle factors in their environment, may all influence vascular function, as those are also taken into account in cardiac risk. However, we didn't assess that in this study. Specifically in our results, we found that older adults in Bern showed a higher B-MORE response than their old counterparts in Montreal. Perhaps the older adults in Bern simply had a healthier microvascular function, which was then reflected in the results of our study. On the left-hand side here, you'll see 2 beautiful pictures of Bern. While on the right, we have the 2 seasons in Montreal, construction and snow, And I think the view on the left would definitely encourage me to get outside, bike to work, have a higher exercise level, and have lower stress. So perhaps these environmental factors did impact the microvascular function we saw reflected here. Overall, from our analysis, we identified the following characteristics as affecting this microvascular function measured by B-MORE: the age, sex, height, BMI, BSA, and the heart rate. I think this preliminary work shows that OS-CMR normal values should be established, and specifically by age and by sex, given the impact of age and how microvascular function can vary with age, as well as the significant differences between the two sexes in this study. This would help reduce confounding in future OS-CMR studies if we have age-matched controls and patients, as well as groups that you look at by the two sexes. Future studies could also include more diverse factors, socioeconomic and environmental factors such as stress, poverty, exercise level, and taking the person's location into account. This would be very interesting to look at if these effects do have any impact on microvascular function. There's actually another study going on at McGill with the CV signature group, looking at these socioeconomic factors, so I'm very excited to see what they'll find. There are limitations to this study. The lack of risk factors was self-reported, so it's possible that some of these individuals could have had subclinical levels of risk that we weren't able to assess. We also did include a few individuals who had a BMI above the normal cutoff of 30, and there was a limited sample size at the Bern site. In future, a large-scale cohort study could look at the prognostic value of B-MORE over time as a snapshot of the microvascular function in an individual. I'd like to encompass all risk factors and available subject characteristics in a study like this to see how they affect microvascular function, not only in healthy individuals, but also in the population in general. From this work, we can conclude so far that in healthy populations, several demographic factors like age, sex, and BSA have differential effects on microvascular function. And in our multivariate analysis, body composition was independently predictive of microvascular function. Thank you.
Thank you, Kate. That was an excellent talk and super interesting about, we kind of alluded to at the very end about the potential clinical utility of B-MORE and how it can really be viewed as a snapshot of an individual's lifetime risk of all their risk factors. And you kind of alluded to already that the research group does have plans to look at other clinical risk factors, including the traditional ones. And obviously, as a women's heart disease cardiologist, we'll be adding other things like other female-specific risk factors and how that differentially impacts B-MORE. We do have a question here from the audience from Jialong He. She asks, what is the difference between B-MORE response and T1 mapping changes after exercise? Maybe this question isn't specific to your per se. Oh, Matthias has his hand up.
Go ahead, Matthias.
Yeah, so,
I'm not too familiar with mapping, so feel free.
Yeah.
Maybe we can do that. I can comment on that. We haven't yet studied that. In fact, we have, honestly, we have tried to apply T1 mapping during exercise and adenosine in a very small sample in Montreal, in a larger sample in Heidelberg. And our results were not really consistent. So I have not further done that. We have done B-MORE in classical first-pass perfusion, and this is also published, where it also can be used instead of adenosine, but it would be a complicated protocol, so it's not something I think I would recommend to use breathing maneuvers for perfusion instead of adenosine. It's just the timing is just too difficult with the contrast injection and so forth. But with T1 mapping, I think I would like to see some more data. The problem with the T1 mapping, certainly with breathing, is that you need a certain time to generate a T1 map. And a cine image that we use is much faster, so can cover the important first 15-20 seconds. whereas a T1 map may take too much time. Yeah. So I just wanted to briefly comment on the interesting finding, and if anybody in the audience has an idea, this is certainly very surprising. This is a healthy population, admittedly, so only 5 of them had an abnormal BMI, but while the correlation with height is known, we know that people with a higher, with a body height that is more on the upper scale, they have a lower risk, and this would certainly also resonate here with the finding that height was positively correlated with the microvascular function as defined by B-MORE. But it's a bit surprising that in this admittedly healthy population, a higher body mass index was associated with higher response. So this may reflect that they have to respond more to this, but by their microvascular function. But this is part of the journey. This is what we have to learn. This is interesting, and certainly we'll have to find an answer in the larger population. But that's why, and we have already enrolled 400 people, healthy individuals here in Montreal as part of the prospective cohort study that Kate mentioned, the Courtois Cardiovascular Signature Program, which is a cohort similar to Framingham, but using a lot of sophisticated markers, and these people will be followed, and they all get B-MORE, so we will hopefully learn from them over the next years.
I think too, Matthias, as a call to action, it's so interesting seeing the, age-matched controls in Montreal is different to that of Bern. Super jealous of you, Kady, that you're living in a Disney movie. But I'm also curious to know of our Chinese colleagues or other Asiatic colleagues on the call. We do know that certain cities, very populated cities like Hong Kong per se, or Taiwan, the proportion of air pollutants is much more, and so I'm curious to know if the B-MORE, if we were to match control that in that population, if it will be quite different as what Kate showed here. And so super interesting to be a potential collaboration with the other members we have here on the seminar today. Okay, any other questions from the audience? No? All right, thank you so much, Kate. So let's get started with our next presenter. We have here Dr. Mahya Khaki. She is a former family physician in Iran, and she's now one of our master's graduate student with Matthias in the Department of Family Medicine. And today she will be talking about the predictive value of the heart rate response to breathing maneuvers for inducible perfusion defects and deficits. Matthias kind of alluded to this already, and so Mahya is just going to go into further detail. And again, welcome. Any questions that the audience have to put in the chat box, but you can also save your questions at the very end and feel free to just share screen and ask it openly as well. Okay, Mahya, it's all yours.
Hi, everyone. Thank you for the introduction. It's a pleasure for me to actually work with this motivated team and have the chance to present my research work here. So I'm going to share my screen. Oh, sorry. Do you see my screen here? Okay. Can you see? Okay, great. So there are very interesting projects actually on the use of breathing maneuver in OS-CMR, as Matthias mentioned. But the study I'm gonna present today is different from other presentations and projects in a sense that this project has a lot to do with breathing maneuvers, but nothing much to do with imaging. Wow, that's interesting. So actually, this project is more about the clinical potential of breathing maneuver, not in cardiac MRI, but in daily office-based practice. So the project that I'm going to present is on the predictive value of the heart rate response to breathing maneuvers for inducible myocardial perfusion deficit. As you know, stable chest pain is a common clinical presentation. So it's very important to follow the clinical guidelines to inform the diagnostic decision-making. Although chest pain guidelines might have changed over time, from old guidelines like in 1991 to the most recent updated guidelines like in 2021, All of them have a stress following the same general algorithm for evaluating patients with stable chest pain. First, further testings need to be done, guided by assessing the pretest probability of coronary artery disease. So as you see here, and second, patients with low pretest probability of coronary artery disease should be avoided to be referred for further testing. And the third, patients with a stable chest pain who are at intermediate risk of coronary artery disease or high pretest probability of coronary artery disease may benefit the most from cardiac imaging and stress testing. However, the literature has shown the overuse of cardiac stress testing in population. A study on the trend of using cardiac stress tests in the US showed a significant increase in the use of imaging stress tests, increasing from about 1 million tests ordered in 1993 to about 3 million tests performed in between 2008 and 2010, which was interestingly that 34.56% of these tests were inappropriate, and it was associated with annual healthcare cost of about $500 million. So the reason for over-testing is multifactorial. It could be because of patients' reassurance, fee-for-services, physicians' preferences, but one of the most important contributor factors in the literature is overestimation of pretest probability of coronary artery disease, by which I mean, for example, a patient with low risk of coronary artery disease would be estimated as intermediate or high pretest probability of coronary artery disease. This overestimation could be because of the limitation of existing risk score tools or predictive models for estimation of pretest probability. Therefore, we thought that application of a simple and accessible stress test gatekeeper might help clinicians to better determine the pretest probability of coronary artery disease, filter patients who do not need additional testing, and better recognize scenarios where imaging is unlikely to improve patients' outcome. So here I'm going to talk about this gatekeeper, which you might have guessed that it is the breathing maneuver. So as Matthias has mentioned, all the studies from 1960s, 80s have looked at cardiovascular response to hyperventilation. And they have seen that hyperventilation can increase sympathetic activity and decrease vagal tone. So in a study on 5-minute hyperventilation, in 369 healthy volunteers showed a significant increase in heart rate by 27% within the first minute of hyperventilation, which was then during also, this is the 5-minute hyperventilation, and also during the 2-minute recovery after hyperventilation, the heart rate started to recover immediately by 20%. So the potential of heart rate response to hyperventilation as an indicator of cardiovascular health was also studied in our team and was published in Nature in 2019. As Matthias mentioned, talked about this in the beginning. In this study, they recruited 282 participants, including controls and patients with cardiovascular disease, including heart failure and coronary artery disease. They looked at the heart rate response to hyperventilation retrospectively as a part of OS-CMR protocol. And they showed that patients with cardiovascular disease, including patients with heart failure and coronary artery disease, had a smaller increase in heart rate in response to hyperventilation. And they showed that cutoff of 15.5 beats per minute had a sensitivity and negative predictive value of 91%, a specificity of 72%, and positive predictive value of 73% for distinguishing healthy individuals from cardiovascular patients. This study was conducted in retrospectively. So we decided to look at the heart rate response to breathing maneuver prospectively and specifically only in patients with suspected coronary artery disease. So the objective of this study is to determine the negative predictive value of heart rate response to breathing maneuvers, hyperventilation followed by breath hold, and to identify an optimal threshold for heart rate response that can be used to rule out inducible myocardial ischemia in patients with suspected coronary artery disease. So regarding methodology, this is an ongoing project. So up to now, we have recruited 57 patients, regardless of history of coronary artery disease, who presented to the cardiology clinic with a stable chest pain or equivalent angina, and were referred to first stress perfusion CMR for further evaluation. In fact, in our study, stress perfusion CMR was the reference and standard to detect inducible perfusion deficit and validate the findings of the breathing maneuver and heart rate. We excluded patients who had atrial fibrillation, heart failure, and atrioventricular block. So in terms of the procedure, these patients were scheduled an appointment for their clinical CMR exam. Before undergoing CMR on the same day, the patients performed a 4-minute breathing maneuver outside MRI, and we recorded their heart rate while performing this breathing maneuver. Afterwards, they underwent first pass stress perfusion CMR for the clinical evaluation, but we also added OS-CMR as a research protocol to their exam. We also recruited 15 age-matched healthy controls without a history of cardiovascular disease. We recorded their heart rate while performing the breathing maneuver outside MRI, and afterwards they underwent a MRI exam only for research purpose to acquire OS-CMR images. All participants stopped taking beta blocker, calcium channel blocker, nitrate, and caffeine 12 hours before their appointment. So here is the slide that shows the breathing maneuver protocol and the device that we used. The same as other studies in the team, the breathing maneuver that we used includes 2 minutes of normal breathing, followed by 1 minute deep hyperventilation at a metronome pace of 30 breaths per minute, and subsequent in expiratory maximal voluntary breath hold. We used FDA-approved respiration sensor to record the respiration pattern, and ECG sensor placed on the forearms to record the for continuous recording of ECG signals. And so the patients performed this breathing maneuver, and their heart rate and breathing pattern was recorded while the patients were lying down supine. You see here the examples of the data recorded by the device. During normal breathing, this is the ECG signal, and this is the respiration signals. During normal breathing, the hyperventilation and breath hold. So this is a recording of one of the participants in this study. This is how the heart rate response to breathing maneuver would look like. The figure on the top shows the respiration pattern, and the figure on the bottom shows the corresponding ECG signal. So as you see here, during normal breathing, the heart rate is very stable. As soon as the patient started to, the participant started to hyperventilate, the heart rate started to increase, and the heart rate reached the plateau here. And when the participant held the breath, the heart rate started to decrease during breath hold. The main parameter that we calculate in our study and we use for diagnostic performance analysis is called breath hold heart rate recovery, or BHR. Breath hold heart rate recovery is defined as the percentage of the heart rate recovery during breath hold relative to the peak hyperventilation heart rate. So from now on, the results that I'm presenting in this study is around this heart rate parameter of breath hold heart rate recovery. So the preliminary results of the study. So in this slide, I would like to give you an idea, just in general, about the trend of heart rate change during hyperventilation and breath hold in 3 groups of participants. The red line here represents patients that presented to the clinic with suspected coronary artery disease with a stable angina, and they underwent MRI, stress perfusion, CMR, and it showed inducible perfusion deficit. The orange line represents patients who had normal perfusion deficit in a stress perfusion CMR, and the blue line represents healthy controls that did not have any history of cardiovascular disease. So as you see here, during hyperventilation, in all participants compared to their own baseline, heart rate started to increase during hyperventilation. And in most participants, the heart peaked in the second half of the hyperventilation. This is middle of hyperventilation, and this is in the second half. As you see here, patients with inducible perfusion deficit had a smaller increase in heart rate compared to the other two groups. Also, during regarding the breath hold, as you see in all three groups, the heart rate started to decrease significantly compared to their own baseline during breath hold, and dropped in the second half to the minimum in the second half of breath hold. And as you also noticed, the same as breath hyperventilation, patients with inducible perfusion deficit had a smaller decrease in heart rate during breath hold. So all in all, we can say that patients with inducible perfusion deficit had blunted heart response to both hyperventilation and breath hold. Here are the two examples of heart rate response in two patients. So the figure on the top is the heart rate recording of a patient with inducible perfusion deficit. As you see, the heart rate started to increase very slightly during hyperventilation, and it started to decrease during breath hold. If you remember, I defined the heart rate parameter called breath hold heart rate recovery. And as you see, that was defined as the percentage of heart rate recovery during breath hold compared to relative to the peak hyperventilation heart rate. And as you see in this patient, the heart rate recovered only by 18%, which is below the cutoff that we acquired in our study that I will explain in the next slides. So the second graph, the figure on the bottom is from a patient with normal perfusion. And as you see, the heart rate increased significantly during hyperventilation. And the heart rate, this marker, heart rate recovered by 39.4% during breath hold relative to peak hyperventilation heart rate, which is a significant response. So in this slide, this box plot shows the comparison of breath hold heart rate recovery between healthy controls, patients who had normal perfusion in the CMR, stress perfusion CMR, and patients who had perfusion deficit after controlling for covariates such as sex, smoking, BMI, and waist to hip ratio. As you see, patients with in perfusion deficit had a significantly smaller heart rate recovery compared to healthy controls and patients with normal perfusion. However, there was no significant difference in heart rate recovery between healthy controls and normal perfusion. This slide shows the impact of sex and age on breath hold heart rate recovery. In the control group, men had a significantly greater breath hold heart rate recovery than women, which could be explained by a higher vagal tone in men, as explained in the literature. But this difference was not significant in patient population. This is in line with the study that I introduced in the background of the presentation that was conducted in our team, that they looked at heart rate response to hyperventilation. They also mentioned that showed that sex does not have a significant impact on the heart rate response. Also, regarding the impact of age, overall age showed a weak negative correlation with breath hold heart rate recovery in all participants. And also, this is in line with that study's results, that they showed that also age did not show a significant impact on patient population. However, with this small sample size, these results has to be tested further after recruiting more patients. So regarding the impact of beta blocker, that I'm sure most of you have thought about it, the comparison of breath hold heart rate recovery between patients who were not prescribed beta blocker at the time of the study and those who were on beta blocker but stopped it 12 hours before the appointment showed no significant difference. This is also in line with the retrospective study that I talked about the heart rate response to hyperventilation. They showed that separation of participants into 3 groups based on beta blocker status did not show any significant difference in heart rate response to hyperventilation. So as I mentioned in the background, if you remember, the primary objective of this study is to determine the negative predictive value of the breath hold height recovery and define an optimal cutoff. Since breath hold height recovery was not significantly different between healthy controls and patients with normal perfusion, we combined them into a single group for diagnostic analysis and identifying the appropriate cutoff. As you see here, the area under the curve for breath hold height recovery was 0.81, which means that our test has a good discriminatory ability. And as you see in this table, the optimal cutoff for breath hold height recovery that could have the best possible discriminatory ability was with a cutoff of 24% change in heart rate. And it was associated with sensitivity of 95.6%, a specificity of 42.3%, negative predictive value of 84.6%, and positive predictive value of 74.5%. It's very important to stress here that this is not a diagnostic tool. Breath hold height recovery is not a diagnostic tool. It is going to be a screening test. It is going to be a stress test gatekeeper. So since the purpose here is to help clinicians rule out myocardial ischemia in suspected patients and identify patients who do not need further testing, sensitivity and negative predictive value becomes very important here. Well, this is very important to show you actually the heart rate area under the curve and the table. But the most important and interesting part of the result that I'm very excited to show you guys is the next slide. That is this nomogram. So this slide shows how this test, breath hold height recovery, can actually inform clinicians' decision-making for better patient selection for a stress test. Here are two nomograms of post-test probability estimation. For people who are not familiar with this Fagan nomogram, I'm just going to explain what this means. Fagan nomogram is a graphical tool that helps us estimate how much a screening test result would help doctors to change the estimation of probability of having coronary artery disease or in general a disease in patients. So to use this tool, first we need to estimate the pretest probability of coronary artery disease before using our screening test or heart rate. So in this study, I estimated the pretest probability of coronary artery disease using 2021 American Heart Association and American College of Cardiology chest pain guidelines for pretest probability estimation. And as you see here on the nomogram on the left shows the pretest probability for patients with low risk of coronary artery disease, which is 11%. And the nomogram on the right shows the pretest probability of coronary artery disease in our study, which is the intermediate or to high risk, which is 34%. So besides the pretest probability, we need also the likelihood ratio of our screening test. Since this is, as I mentioned before, this is a screening tool, and this tool aims to help doctors rule out myocardial ischemia, the negative likelihood is very important here. And as you see, the negative likelihood in our test, in our study was 0.12. So with this information, like having pretest probability and likelihood ratio, this tool connects the pretest probability to the post-test probability, considering the negative likelihood ratio of our test. And as you see here, interestingly, in patients with high to intermediate pretest probability of coronary artery disease, performing this test would decrease the post-test probability to less than 7%, which based on the most updated guideline in 2021, less than 15% is considered low risk. So basically in this study, using this screening tool could reclassify patients from intermediate to high risk to a low risk patient. And as you remember, in the beginning of my presentation, I talked about the problem of overestimating the pretest probability of coronary artery disease, that there is this tendency, and also this leads to over-testing. So you see that how it could really reduce the pretest post-test probability. Also in patients with low risk, I mean, here the probability, pretest probability is 11%, that for some doctors, clinicians, it might be still concerning. Performing this test would decrease the post-test probability to less than 2%, which would be very less. So based on this result, it seems that the birth hold hydro recovery would allow for clear reclassification of patients' risk and can be a stress test gatekeeper for getting the right person to the stress test. Here, I'm gonna present a case that I had in my study. So I had a patient who was a 45-year-old man that presented to the emergency department with exertional chest pain without shortness of breath or palpitation. He was a heavy smoker without family history of coronary artery disease. His ECG stress test was inconclusive. So the patient was referred to first pass stress perfusion CMR for further evaluation. And interestingly, as opposed to the expectation, the heart rate response was really relatively significant in this patient. If you remember, I talked about the cutoff of 24% for birth hold heart rate recovery. And as you see in this patient, the heart rate recovered during the birth hold with 27% recovery. So this is very interesting. And when you compare this result with this adenosine stress test, you see the patient did not have any inducible perfusion deficit. If you want to look at based on the screening tool, this patient had a negative screening test. And if this test could be used in real life practice for this patient, it would have avoided unnecessary testing in this patient. So it could be a stress test gatekeeper. But there are some limitations in this study. So the sample size was relatively limited in this study, which may limit the power of our analysis. So the study results will have to be verified with larger sample size. Also, there are very few number of participants with positive stress perfusion CMR that underwent angiography. Having coronary angiography results would allow us to assess the performance of the addition of birth hold heart rate recovery to stress perfusion results. But we are still continue recruiting patients, and this project is ongoing. So we will see how many patients at the end will get their angiography. So the conclusion is that the birth hold heart rate recovery could serve as an efficient, accessible pre-imaging screening tool, or as a complementary marker in combination with stress perfusion or breathing enhanced CMR protocols. Application of such tests could result in substantial savings to the healthcare system without reducing the quality of care. Thank you so much for your attention and listening to my presentation.
Thank you very much, Mahya. Very, very nice. I think it's interesting to have a talk not related to imaging as part of an imaging symposium. But as you mentioned, this could serve as a screening test to better select patients for such an imaging procedure, but also could add an additional parameter to multi-parametric evaluation of the scan, as I mentioned before. There's a very interesting comment from Sheldon Machter. He's a professor of medicine and physiology here with the Department of Physiology and Division of Experimental Medicine. So he says that the fact that the beta blockers did not have a significant impact that you found, as you described it, probably reflects that the vagal tone is the leading part here, not so much the sympathetic tone. So thank you very much, Sheldon, for that comment. So I have just one question, and everybody else in the audience, feel free to post if you have any in the chat. The question I have is maybe, Mahya, as you mentioned, your sample size is limited, but maybe you can briefly explain what your next plans are for your project, how to increase the sample size, and also how you think this could be applied in clinical scenarios from a technical point of view. Do you think it's okay that a doctor just does this breathing maneuver in the practice, or do you think we will need a device or something? Maybe you can comment on that.
So Yeah, sure. Thanks. So basically, right now we are developing this screening tool. The next step is to validate this screening tool internally and externally. So our plan for recruitment is to keep recruiting patients in the McGill University Health Center, and also, of course, involve like other centers that would be interested to collaborate with our project to be able to do a multi-center study to increase the number of participants. But I think in terms of the clinical application, I think it's based on my experience with patients, even patients who could not do a very deep hyperventilation, still the heart response was significant. So it would be easy to ask the patients to perform this hyperventilation in the clinical setting. But I think using a device or app that could help doctors to pick the maximum heart rate during hyperventilation or during birth hold would be very helpful. Like there are apps for Apple Watch or iPhone, and also there are this device that can, with the accelerometer and different technologies can look at the breathing pattern and heart rate response. So I think it would be very interesting, and our next plan is actually to develop a device or app, and then we can validate that app also on our patients so that we can help doctors to use it in the future in the clinic.
Yeah, no, I totally agree. And machine learning crawled into every aspect of imaging, but definitely would also help in a better understanding of the heart rate response. We have seen very exciting results on analyzing ECGs, even being used for identifying heart failure or diabetes just in the ECG. So I think it should be possible to further analyze the heart rate response, the rate of the response, and the extent of the response and such. So thank you very much, Mahya, for these exciting data, and also use this opportunity for thanking you for your great work. She's working really relentlessly and with a lot of energy on this. So it's now a pleasure for me to introduce the next speaker, who is equally important to the whole development of this area. She has been with us for years, started as a master's and is now finished with her MD-PhD program. She's currently in Edmonton, but still involved in our work, either remotely or being present here. I'm talking about Liz Hillier. She has been involved in several studies, and she will talk about novel biomarkers derived from oxygenation-sensitive MR. So Liz, the floor is yours.
Thanks, Matthias. Just before I start, Judy, I saw your hand up. Did you have a comment?
No, it's just in relation to, how exciting Mahya's work is about the potential, prognostic data that this also has, someone who has a blunted BHR, breath hold, heart rate recovery response, and we have so much information to look up. And then how it'd be interesting to collaborate again with other international centers to define how this will change, as a clinician scientist, like if you use this, if you don't use this, how it does change that clinical trajectory of the patient. So these are all very valuable information to get, and it would be a call out again to a multi-center collaboration for both prognosis and changing clinical management for this heart rate variability data we have.
Thanks, Judy.
Oh, and there are some comments from Liz. Oh, I think Liz K, I think we've already addressed those.
Okay, then I will get started. So I don't think there could be a better intro than Judy's comment just now to my talk. Can you see my screen? Nods? Yes? Okay.
Yes, we can, yep.
So my talk is called Novel Biomarkers Derived from Breathing Maneuvers in OS-CMR. So I'm not going to introduce a ton new here, but what I do want to do is summarize what we have so far from this technique. So we've heard about a couple of things today, and I'm just going to highlight them again and kind of break it down into concepts. So the first thing I want to start with is a figure I've modified from Colin Berry's commentary from a Circulation article from 2017, where he's talking about, this conundrum of most of the established diagnostic pathways we have historically have been for identifying obstructive coronary artery disease. But we know, and it's a really hot topic right now in cardiology, that ischemia with no obstructive coronary artery disease or myocardial infarction with no obstructive coronary artery disease is a really big thing with important clinical consequences and implications. So working on pathways and methodologies that can identify this and distinguish it is quite important. So I just want us all to keep this in mind in terms of a framework for what OS-CMR and breathing maneuvers really can investigate. So our historical biomarker is the global breathing enhanced myocardial oxygenation reserve. So we do our breathing maneuver and we look through breath hold at what's happened. So Kady Fischer has been a pioneer along with Dominic Gunch in this field, and she's talked a lot about this already, so I won't belabor the point, but that was historically and in the beginning a global marker where we can see differences here with the adenosine with hyperventilation, and then the B-MORE breath hold after hyperventilation. We then moved into more regional markers, and Judy has worked on this as well, which she talked about, just looking at how cardiovascular risk can be associated with a transmural gradient, and she published this paper highlighting this quite well. So historically, and I think that we all know this when we think about, okay, these pretty images, especially that have come from Kady Fischer, the obvious thing to look at with OS-CMR is an area that has an obvious deficit and an area that doesn't. We can come up with this. And so Kady's talked about this earlier, but you can have these regional abnormalities, especially in significant obstructive coronary artery disease, that we can really identify quite well, and along with the global marker here. So then we move into INOCA, and this was a real challenge for us in coming up with, okay, how can we look at this? Because when we looked at the global markers in a patient population with INOCA versus healthy volunteers, there was absolutely no difference, and nor would we necessarily expect there to be if there wasn't a lot of significantly progressed underlying disease. So the global markers weren't different when we looked at that. So we had to come up with these regional markers. And so what we did, and this is based off of studies that were published before, not necessarily in OS-CMR, but we broke this down into epicardial and endocardial territories. And then we just came up with a marker of heterogeneity. So essentially what we did is per slice with the 12 subsegments, we just created sums. So we looked at the sum of the differences radially, circumferentially, and longitudinally. And this is a figure from the review paper that I published, but it's a figure modified from the research letter in Circulation that we published earlier this year, looking at regional heterogeneity of the B-MORE in INOCA compared to healthy women. And it was quite significant. So what we found is there's these pockets of regional heterogeneous myocardial oxygenation reserve in patients with INOCA compared to healthy. We also then, that was as I explained, a manual calculation that we did in Excel. We broke that down in the subsegments. What we did with the help of Mitchel Benovoy from Circle is we created an automated analysis of this. So we took a couple of different MATLAB codes, and with the automated contouring that we now have access to, which he will talk about right after me, we were able to replicate this significance of regional heterogeneity with automated markers of regional heterogeneity. So something called entropy, we looked at neighborhood standard deviation. We looked at a couple of other things, and they were still as significant. So this wasn't us, just looking at things manually, finding something significant. We were able to replicate this with an automated contouring method. And that was pretty exciting for us. Another thing that OS-CMR with breathing maneuvers has looked at is heart failure. Kady just had an amazing presentation on that, especially with HFpEF. I've looked at a study that we've submitted for publication in global heart failure, so HFrEF and HFpEF as well. We found that globally, there is a significant difference with just a global marker. Patients with heart failure have a reduced myocardial oxygenation response when compared to healthy age-controlled volunteers. The other thing that we've now done in that same study I just talked about is look at the oxygenation response of the vasculature in both the heart and the brain. So this is kind of the central illustration from this paper that we've submitted for publication, but we were able to look in both of these vascular beds in the same scanning session. And what we found is that there's microvascular dysfunction in heart failure, both in the brain and in the heart of these patients with heart failure. And this is correlated to impaired cognitive status, and they're correlated to each other as well. So this is, again, highlighting the reduced cerebral, this time, oxygenation reserve in patients with heart failure, and how the myocardial and cerebral oxygenation response are correlated to each other. And as I mentioned before, we were also able to correlate this to mild cognitive impairment as assessed with the Montreal Cognitive Assessment Test. And these are just two images here of the global response in a patient with heart failure with an ejection fraction of 24% and an ejection fraction of 60%, and the differences there. And this sample size wasn't huge. I think we had about 26 patients, so we weren't able to do a sub-analysis based on ejection fraction, but I think that Kady highlighted very well the findings in HFpEF specifically. So one of the things that we've moved into quite recently, and I think it builds on some of Lindsay's findings in the differences between the global myocardial oxygenation reserve response in Bern compared to Montreal, and we're seeing differences there, and that might be due to location, just kind of from an epidemiological point of view, and it also, we are not sure yet, but it might be due to the sequence itself. And so we haven't investigated that more, but one of the things we wanted to do is come up with different biomarkers that we could from these images. So we've now come up with something that we call the normalized MORE. And so what we can do here, and Mitchell will talk about this after, where he can use the automated contouring in the new module we have access to, can do a lot of the calculations itself. But what we're doing is we're normalizing to the left ventricular blood pool. So we're saying that the left ventricular blood pool is 100% oxygenated. It's the most oxygenated blood that we're going to get. And then across the entire cardiac cycle, we can look at the pseudo SpO2, we call it, in the myocardium, and we can see differences from diastole going into systole with the energy extraction and the oxygenation extraction there. So that's really interesting for us, being able to do that. We can also normalize it to the right ventricular blood pool and get different results and compare it there. So that's one of the things that we're able to do. And what this does is it normalizes it per person. So we can maybe take out some of the confounding effects that we're seeing, whether epidemiologically, whether not based on the sequence of different locations. And we're really hoping that that can help us out. So moving beyond, the signal intensity specific biomarkers, we've heard just most recently from Mahya, but also from the paper published by Selwyn Hawkins and Kady Fischer in 2019, the impact that heart rate can have. So we're getting a lot of markers from this methodology of the breathing maneuvers with OS-CMR. We also are getting information on strain. So this is just breathing maneuver with the F-sync sequence, which Marco Ox talked about earlier. And we've also been able to extract strain information from the OS-CMR images in and of themselves. It's a modified SSFP sequence, so we can look at strain on those images. And so what I did in this study, which was presented at EuroCMR in 2019, and we're just finishing up the analysis right now. This is a study with people who are younger than 30, and there's a cohort of healthy people, and there's a cohort of people who were born very preterm, so at less than 27 weeks. And we're really investigating the impact of an exercise program, a 12-week exercise program, on these two cohorts, and we're comparing them. So we looked from the OS-CMR images at strain parameters. So on the left there, you can see at baseline, and then in the middle graph there, you can see after exercise intervention. So at baseline, there was a peak strain difference longitudinally between these cohorts, and after exercise intervention, there wasn't. So we were able to detect subclinical findings and very subtle differences that were able to improve or at least normalize the strain differences in these two groups. So to summarize, what we have, and this is just a little bit of the snippet of what we're working on right now, is we have the global parameters, so the B-MORE that we're all used to. We have regional parameters, the transmural and the heterogeneity markers that I've talked about. We're starting to look in different organ systems altogether. We have this new way of looking at things that we're normalizing to. So can we take away some of the confounding effects or the differences that we're seeing between sites. And then we're looking beyond just the signal intensity in and of itself in terms of oxygenation. We can look at things such as heart rate and strain, not just strain at baseline, but strain during stress. So strain after hyperventilation, strain during the breath hold, and we can start looking at temporal dynamics of all of these responses. So all of a sudden, we've been inundated with so much data that this becomes a statistical nightmare, at least in my opinion, because stats is, I'm okay at it, but I'm not gonna, figure out 50 things to do. So Mitchel, Benovoy, and his team at Circle Labs came up with a radiomics algorithm that we call Cardiome. And he will talk more about it in his talk right after me, so I'm not gonna delve into the depths of it. And this will be a little bit of a teaser here. But what we did in this analysis, which we submitted for SCMR 2022, is look at a patient population where there was a positive, there's a positive test, in clinic, and we wanted to figure out if they had a positive stress test, do we have to send them for angiography? Could we delineate or differentiate between obstructive CAD and INOCA? And so what we did is we came up with 670 naive biomarkers. So 670 is a lot more from the global marker we were looking at before. And what we did is we put this in the radiomics algorithm, and it came up with, it spit out the top classifying biomarkers. So this is a very naive analysis, but like right out of the box, we came up with a 73% classification accuracy for determining between significant obstructive CAD and ischemia with non-obstructive CAD. And interestingly, the top biomarker that I identified as classification on here was this normalized MORE, so normalized to the left ventricular blood pool. And so here on this kind of plot, to the left, the blue dots that you can see there are significant obstructive CAD, and the dots that you can see on the right are not significant obstructive CAD, so INOCA. And this was able to very clearly tease out with a lot of accuracy who had significant obstructive CAD and who had INOCA. So this was a very naive analysis. This was kind of the first iteration we had run, and we got 73% classification accuracy with these parameters. So we're pretty confident that we can increase that. Notably, the other biomarkers that it identified as having or contributing significantly to accurately classifying between these two groups are segmental breathing enhanced myocardial oxygenation response to stress, or as Matthias mentioned earlier, to the hyperventilation. So we're not quite in the breath hold yet, but this is after hyperventilation, along with the epicardial MORE. So globally, just in the epicardium. And we haven't really teased out why these might be affected. Is epicardial more significant than endocardial because of findings that Judy has found before? Potentially, could it be confounding effects of potentially the blood pool? We're not sure. So this is really exciting for us. And for me specifically, the presence of cerebrovascular disease in helping to tease out, the INOCA versus the obstructive CAD, and how that might play between the heart and the brain, a lot of factors here. So this is just a little tease, and Mitchel will talk a little bit more about the new module we have, which is making all of this possible. And then tomorrow, for those of us who are going to join us, we're going to go through case examples where we're going to talk about some of the markers that I've just talked about with the module that he will now talk about. So I want to thank everyone who made this possible, like Matthias, like Judy. We wouldn't be able to do this without our whole team. So thank you very much.
Thank you so much, Liz. That was an excellent talk of all the potential clinical utility of B-MORE. And I just love your slide, how you showcase the different, the heterogeneous phenotype of ischemic heart disease. You have the stable, you have the acute, and then you have the end stage heart failure. And then you throw in the complexity of the non-obstructive disease, so like INOCA, MINOCA, HFpEF. And so we're really only scratching the surface of all of this really, iceberg. And I think B-MORE and OS-CMR could really be at the forefront of the diagnostic modality of this. And so and we are running a little bit ahead of time, so I want to throw it out to our other collaborators who are on the call, to think about what are you guys doing with your OS-CMR? Do you have any other biomarkers that are coming on the top of your head? We have a comment here from Sheldon at 11:47. Sorry, Sheldon, about, I'll come back right up to it. He mentions to Liz too, like, you should distinguish coronary artery, meaning a stenosis, so I presume epicardial stenosis, which could be acute or old, versus that of atherosclerotic plaque, which have not ruptured yet have the propensity or risk of producing a future event. And so that's a really good comment. As a OS-CMR researcher, I'm not too sure how we could show that. Maybe Matthias has some ideas, or other researchers out there, how we can characterize the stability of atherosclerosis. I think you're kind of referring to CT coronary angiogram, coronary artery calcium score. And so that's a really good point you brought up there. I see Matthias raising his hand.
Yeah, so I think that's an excellent comment here. Interesting. So it's about, again, just as I understand the comment is, we may be able then to differentiate or help differentiating coronary artery stenosis from just the presence of a plaque that may or may not be unstable. So we know that infarcts are not necessarily caused by high-degree stenosis, but by plaques that either rupture or erode. So is there a way to identify such an area at risk that is not necessarily exposed to high-degree stenosis, but turning into an unstable plaque? And why is that? So there are very old data. I think the first one was in rabbit aortas in 2002 by Andrew Taylor, who was in Australia now. He has shown that if you irritate arteries that downstream, so an unstable plaque, even not causing any stenosis, would release cytokines and other vasoconstrictive and inflammatory components that in the periphery of this vessel, even though there's no stenosis, would cause microvascular dysfunction. So that means if we have a window to microvascular function, as we do with B-MORE, then we could even identify an abnormal coronary territory in the absence of significant stenosis. Another example is that if you perform an angioplasty in a high-degree stenosis, actually during the first 12 to 24 hours, perfusion is not back to normal. And simply because by the intervention, you release a lot of kind of debris and material that causes some peripheral inflammatory response and vasovascular dysfunction. So if we now have a way to visualize that in a regional fashion, that would maybe even help in identifying vessels where the abnormality doesn't come from stenosis, but just from the presence from an unstable plaque. So that is and Sheldon, you have another comment here. You might look at markers of flow-mediated dilation. In fact, we have done this many years ago that we looked at flow-mediated dilation in the periphery and using oxygenation-sensitive MR. And this is actually associated with an overshoot after releasing for flow-mediated dilatation, where you first compress the vessel and then you release it and then you have an overshoot. So we have done that. In the coronaries, of course, that's a bit more difficult, but these could be interesting markers. Yeah, but the microvascular dysfunction that shows the potential of B-MORE, that if we can see that in a regional in a map, then we would see, of course, regional variations, but of course, then global abnormalities, which we may not see with other techniques. And that's where, Judy, you and your interest in global microvascular dysfunction in women comes in. Yeah.
Yeah, like on that point, tomorrow we're going to showcase one of our examples, one of our collaborators in Cincinnati, Ohio, Dr. Odame Kasade. Both her and I trained in women's heart disease, cardiology, and Cedar-Sinai. And so again, call out to our other collaborators I really find utility in this OS-CMR specifically in the woman population. It's non-invasive. There's no adenosine. Especially postpartum. There are a lot of these females are breastfeeding, and so they can't be predisposing themselves to the risk of gadolinium and pharmacological agents. And so if there are any other researchers out there who are interested in the women cohort, we're only scratching the surface, and we want more ideas from especially multi-center sites, different ethnic populations. We now recognize that not only women's hearts different from men, but there's a different dynamic when you throw in ethnicity, race, location, environment. And so we can study all we can in Canada and the US, but we really want to reach out to our European and our Asian collaborators. And so keep your thoughts you have and ideas together, and then tomorrow with the open discussion, it'll be really exciting to hear from you. And then again, another comment from Sheldon here. Love your comments, Sheldon. You're like really A for participation. So he says, maybe you could induce temporary hypertension with a phenylephrine dose. Okay, good thought. I mean, we'll have to get through ethics with the phenylephrine.
It's definitely something to discuss with the ethics committee. So should we decide to do that, we'll call you for help. But otherwise, what you just said, Jody, I can just reinforce that. This science is not meant to be something Montreal or whatever, Heidelberg or Bern. So whoever is interested, we are sharing a lot of our knowledge, in fact, all our knowledge to help others to get started, be it the sequence that we can share. We have, so in Heidelberg, we use a Philips system for that. In Montreal, we have Siemens and GE. So whichever system you use, we will probably be able to help you out with a sequence that you need. And it's actually not a kind of a protected sequence. It is a sequence.
Just whoever is unmuted right now.
Yeah, I don't know who is. It didn't come from me here. Okay, so it's a sequence that is basically just a modified SSFP sequence. So it's not something that requires huge development on the sequence side, and certainly the sequence can probably be further improved. But what we already have is already very good. So again, I just wanted to reinforce what Judy just said. Who is interested, please contact us, and we can help out with protocols, sequence parameters, etc. So back to you, Judy.
Yes. So we have our last final speaker, but doesn't mean it's not any good. So super excited to hear. We have Mitchel Benovoy. He's our vice president of Circle Labs, our cardiovascular imaging. I've had a pleasure to work with him over the last several months here, and it's always a cerebral discussion talking to a really advanced scientist. And so he will now be talking about the fully automated analysis of OS-CMR and giving you a glimpse into his research, as well as cardiome that Liz touched base on. And this is a preview to what we will also be showcasing tomorrow on day 2. So definitely stay tuned for that. So take it away, Mitchel.
Thank you very much, Judy. Can you hear me okay? All right. Well, good day, everybody. Following my talk last year at the Symposium, I'm very delighted to update you all about Circle's continued development of our OS-CMR post-processing tool. Now, keep in mind that this is still a very much research module. But we're very close to having a comprehensive and stable version that we'd be able to distribute to interested parties. We'll be taking some names tomorrow after the demo. Here are my disclosures. So in the context that OS-CMR is a fairly new paradigm with lots of things to discover still, we wanted to ensure that our post-processing tool would be versatile and agile to allow the users freedom to test different hypotheses quickly and unconstrained. So first and foremost, we need to support the different breathing states of varying lengths. We want automatic breathing state identification and cropping which is still under development for now, but that's coming up. We need automatic pre-processing of the data because, as we all know, the OS signal in these data sets is quite subtle and in many respects quite fragile, at least in an engineering perspective. So we need to have some intelligent noise and artifact suppression technologies, and importantly, mechanisms to boost the signal to noise ratio. Following that, automatic post-processing in the form of automated contouring on all slices and phases was certainly a must and highly requested. After that, automated biomarker computations. And of course, all of this has to be backed up with full manual controls in case of failure of various AI systems, which are quite numerous in this tool. So the primary breathing paradigm we designed the module around is a 4-minute acquisition preceded by an optional 15-second baseline breath hold. But note that the module can accommodate variability in the durations of each of these breathing states, and these states can themselves be moved around or changed. So for example, you can skip the free breathing phase and or replace it with something else. The module will adapt to that. So this is what it looks like. And as you can see, it's a module fully embedded within CVI42. Which allows you to use all of the other modules to perform your standard comprehensive analyses of your patients or your volunteers. And I'd like to point out particularly our automated quantitative perfusion module, which we think can be a very strong reference standard for validating OS-CMR through the absolute quantification of the blood flow. At near the same resolution of the CMR images. Now the operation is quite simple. You just need to find your continuous acquisition study in the series list and double click on it. And you're then prompted to enter the start and end phases of the different breathing states. Now note here that we're working on automating this cropping step, but for now, this takes just a few seconds to fill out. So once you've entered the timing information, the breathing states are cropped temporally and arranged, and the appropriate columns and the pre and post processing is triggered automatically. And we get these contour data sets at all slices and phases, and all of the biomarkers have now been computed. But before we look at those, I want to talk about what's going on behind the scenes, because although the automatic contouring is nice and a huge time saver, the big evolution we think is in the way we process the OS data under the hood. So let's imagine we have a 4-minute long continuous acquisition. The first step is to crop it into the different breathing states. And now because these breathing states last several dozens of seconds, they contain a lot of repeating cardiac cycles. And knowing that the OS signal is relatively subtle and noise can be quite severe, especially with the active breathing states, we came up with a way of leveraging these repeated measurements. And this is how we do it at a high level. The first step is to create this large phase match matrix where we automatically identify and isolate every complete RR cycle and stack them all like what you see here, row over row. So every column contains the same phase of the cardiac cycle repeated n times depending on the length of the breathing state. And then phase-wise, we align each pixel across the n cardiac phases. So we can now imagine that we have a stack of tightly registered images for each phase down the n cardiac cycles. And then we apply our artifact suppression and signal to noise ratio boosting algorithms to effectively distill the information contained across the repeated measures into a composite RR series that is considerably cleaner in terms of noise and artifacts, and also presents with an increased SNR. Now, on this composite series, we compute most of the biomarkers and present them in the results panel, which you can see here. So these are the different representations of the biomarkers. We have the high resolution pixel-wise maps. You have the temporal single intensity curves here per AHA segment. And we have the AHA polar map decomposition also. You can toggle through all of these representations dynamically. These are dynamic panels too, so you can see the evolution of the biomarkers pixel-wise over time. So this really allows you a really comprehensive, really in-depth view of all of the biomarkers that you've computed. Now, on the topic of biomarkers, we've come up with a fairly large list of quote-unquote naive biomarkers, where it's still somewhat of an open question as to which ones are diagnostically performant. So at this point, I want to introduce Circle's cardiome system, which was teased by Liz Hillier. So cardiome is a proprietary end-to-end biomarker discovery platform that is closely coupled within CDI42. And we can work on either a standalone workstation or through a multi-center federated deployment. It can ingest heterogeneous classes of biomarkers such as imaging, serum reports, demographic, environmental factors, genomics, you name it, it can use it. And then it reports on biomarker saliency or biomarker importance, biomarker polarity, which indicates which biomarkers push towards disease state or a healthy control state. And finally, you can train and deploy classifiers or prognosticators to be used either retrospectively or prospectively. So applied to OS-CMR data, all of the naive biomarkers computed in CDI42 are arranged in this big naive feature matrix. And given pathological and control labels, it'll tell you which ones are useful, how useful they are through this ranking, and show you the magnitude, how the magnitude of a biomarker pushes the subject into either a disease state or a control state. So as an example, on this small cohort of positive CAD patients and healthy controls, we wanted to see which of the OS biomarkers led to the classification of patients with coronary artery disease. And in this case, very interestingly, our pseudo oxygen saturation biomarkers that were introduced by Liz Hillier were found to be salient. In fact, out of several hundred biomarkers, these are the top 3 that were picked by cardiome. And it also gives you the timing where they are salient. So we have LV SpO2 at end diastole, RV SpO2 at end systole, and LV SpO2 at end systole also. So you see the kind of the relative power of each of these biomarkers here. So this is what we call saliency. And now for the polarity analysis, which I think is even more interesting, this plot here shows that the higher the pseudo-oxygen saturation is at either end systole or diastole, the more the system is likely to classify you into as a healthy class. And inversely, the lower your saturation is, the more you are prone to be classified as a CAD positive patient. Now, this allows you phenotyping of these disease states through the ton of biomarkers that we're computing, and we've used this in quite a few disease, well, not that much, but a few disease states so far, and it's been extremely informative in a clinical research context. And on that, of course, we certainly welcome some multi-centric data to continue exploring the biomarker landscape related to OS-CMR. So tomorrow we'll be opening up the floodgates to allow data sharing and collaboration on that. And on that, I'll end here, and I'll invite you all to tomorrow's hands-on demo of the OS-CMR module and some more interactive discussion on biomarkers and how we can apply not only the module but the cardio to push the discovery. Thank you very much for your attention.
Yeah, well, thank you very much, Mitchel. And I have to say, again, I disclosed initially my involvement in Circle, but nevertheless, I think I can speak for everybody working here and elsewhere. They're all very thankful for your work and the work of Circle in providing the tools that allow us in a reasonable amount of time. And I know that Liz, for example, how many hours she spent in tracing and then transferring data into tables, and so for her alone, I think maybe Liz, you can yourself say how long it would take to analyze a data set with all the phases through all the maneuvers, and then how long it takes with this module.
I mean, we used to only do like an systolic phase, so I'd end up contouring and someone hold their breath for, let's say, a minute, 5, 6 end systolic phases. That would take 2 hours to get it right. So if I had to contour entire cardiac cycles, this would be 17 people's full-time jobs. Like it'd probably, in all honesty, take 24 hours. And now, you know, depending on the computer, it can take 5 minutes max, but that's with motion correction, that's with co-registration and everything that Mitchell talked about. So we're not even on the same playing field anymore. The opportunities that this has opened up for us is exponential.
And I think that also offers now the fantastic opportunity to not only do the analysis, you said, end systole, for example, but also understand the dynamics throughout the cardiac cycle. And beyond that, detect certain response patterns over time. And then on top of that, also doing that all with machine learning, and then adding other parameters, as Liz, in your beautiful talk, as you mentioned, so other markers that come on top of that. And Mitchel, as you mentioned, clinical information, then the heart rate response that we have discussed today as well, which is automatically part of that. So I think that the richness of the data is just unparalleled. And of course, having a tool that can bring this all together will be very, is a key to the success here. Yeah.
There's a comment from Nicola Martini in the chat.
Yeah,
probably.
Yeah, so she's asking, how can we manage the through plane motion due to different breathing levels during hyperventilation? So I don't know who wants to take that question. Mitchel, do you want to?
Very hardly. That's the biggest problem that we still have is the through plane motion. We have excellent in plane motion correction, but because these are 2D acquisitions, it is a problem for now, unless we move to 3D, native 3D acquisitions, which we're significantly investigating.
Yeah, and keep in mind, Nicola, that a lot of the information is actually in the post-hyperventilation recovery. That refers to the heart rate, but also to basically to the normalization. The most of the difference that we see for the heart rate, but also for others, is between the very end of the hyperventilation and the stable recovery in breath hold. And then, of course, some people may ask, okay, you say a 1 minute of breath hold, are you kidding me? Nobody can hold their breath for 1 minute, let alone patients. But for those who will attend tomorrow morning, I invite everybody, and we've spoken about that with Sylvia and Mahya, our wonderful technologists, who will perform the live demo tomorrow morning. I would invite everybody to join in and do actually with the patient in the scanner, the breathing maneuver. and then feel yourself that after having hyperventilated for a minute, for I think more than 90% of you, holding the breath then for a minute will not be a big issue at all. It sounds like a big thing, but remember the urge to breathe comes from having too much CO2 on board. But if you have hyperventilated, you basically exhaled all that carbon dioxide. So it takes a lot of time to then come up to levels that are uncomfortable. So that's why the long breath holds are not a problem, especially not for the 30 seconds after hyperventilation. And maybe yeah, Liz, you can also say how many of the patients with heart failure, and also invite Mahya and Kady to comment on that. How many of those have troubles with the 30-second breath hold? Maybe Liz, you can say how often you see that in your patients.
Yeah, I would say between like around 15% for the first time. But what we find actually is the biggest problem is that people aren't hyperventilating correctly. I think they get nervous or they're not sure how to do it. Once we actually get people performing the hyperventilation properly, I think I've maybe seen 2 where they haven't actually been able to hold their breath, like 2 out of the 400 people that I've witnessed scanning, and maybe Maggie and Sylvie probably are actually the best. So what we do highlight, and I'm sure we'll highlight this again tomorrow, is that the training of this and getting participants to actually do the breathing maneuver with us outside of the scanner so they get used to what we're doing and what it feels like is the most important, because it's very rare that I see somebody who can't hold their breath for 30 seconds.
I would say one of the oldest patients that we did a hyperventilation was an 84-year-old lady, and she was able to hold her breath for about 55 seconds. So she was a real champ. So once they get to the rhythm and again, you know, do the belly breathing, it's actually very doable.
Yeah. So I'm looking forward to tomorrow, where we can discuss these practicalities and the challenges with the actual performance, or whether there are challenges, and if so, how to meet them. There's another comment from Jan Lohan. Since it's an SFP sequence, can you apply compressed sensing to accelerate the acquisition? I think that's a good idea. However, the compressed sensing itself may pose a little bit of a problem. Maybe Mitchel, you can comment on that. I think we had discussed that before.
Yeah, it's something we want to look at for sure. But given the small SNR of the native bold signal, the native OS signal, it might be a challenge there with compressed sensing. But we're looking into that. You know, so where we want to eventually go to is a 3D compressed sensing, free breathing acquisition. It's looking pretty good, but it's still a super early research project.
Another one from Itibella around the motion. So question is, could there be something interesting in using systolic versus diastolic values? And this is exactly one of those. There's an interesting publication from Debbie Auli's team. I think Rohan Dharmakuma is the first author, who a couple of years ago have studied using that sinus SSFP sequence, the relationship between diastolic and systolic signal intensity, or in other words, oxygenation, and found even a difference in patients with, when comparing patients with coronary artery disease to healthy controls. So there is definitely an interesting piece of information there too. We know that coronary blood flow is biphasic, so we have also observed so far in the initial data that this apparently is also the case for the B-MORE, and or for the oxygenation data. So we definitely need to evaluate that and go into that as well. Within the cardiac or between cardiac phases, that there is also information in how the signal evolves. And so that's definitely a very good point. And then, of course, you then reduce the number of confounders massively. And I think we already are reducing a lot. So it's the same patient in the same scanner during the same breath hold. So there is not much happening here other than the beating heart and the signal that is largely determined by the presence or absence or the amount of deoxygenated hemoglobin. So, yeah. Any other points? Yeah, so Andrew Korstein, he's our physicist here at McGill, is answering that to that question from regarding compressed sensing, saying it's basically a looped cine, so any acceleration you can do on a regular cine would work as well for OS imaging. It's just that the reconstruction, anything you do to the signal, cleaning it up by machine learning, for example, of course, has to be done very carefully in order to avoid that, this, as Mitchell mentioned, avoid that small or relatively small changes are somehow overshadowed or just not detectable anymore. Okay, so we are, because everybody adhered to the time, which is great. We are very good in time. So if I may have a little summary of what we have done. So we have, I think, seen a lot from different groups working with this method, that the combination of oxygenation sensitive MR with a breathing maneuver, specifically hyperventilation followed by a breath hold, is apparently a robust marker for coronary vascular function, both on a global and a regional level. It has been validated in animal studies, in volunteers, so in healthy people. It has been applied to various patient groups, including patients with global microvascular dysfunction, patients with perfusion deficits, patients with heart failure, patients with stable coronary artery disease, patients with acute coronary syndrome, so unstable coronary artery disease, patients with recent acute myocardial infarction, patients with HFpEF. We have also seen that, and Kate didn't, let's say, mention that, but she's also actually working on establishing normal values, age and sex specific normal values. So far, using the cohort here from in Montreal, the Courtois Cardiovascular Signature Program, we have already included more than 400 participants for that, and another 3,400 are planned. So a lot is happening, and we are, I think, way beyond the point of no return. So this technique will come, and it will definitely provide a lot of very important information. And just keep in mind, this is not to be meant as a standalone, but it's meant as part of a comprehensive cardiac MR scan, where the other components, ideally also short and simple protocols, give information on volumes, morphology, function, mass, and the tissue composition. So taking that all together, to me, it's hard to not think about this leading into a new era of cardiac MR, where we simplify the scan, we make it shorter, and we get rid of contrast agents or any other reasons for putting the needle in these patients. So a lot is happening. Today we gave an introduction to the topic, talked about the history, the evidence, the protocols, and showed currently published but also not yet published data. So in terms of what we're planning for the next for tomorrow, I'll come back to that in a minute, but I wanted to first give Judy and also a chance to provide her summary and view as someone who has a strong, genuine interest in vascular function and new ways to assess that.
Yeah, absolutely. I think my takeaway from today is just the clinical potential and how, as a clinician, both scientists and cardiologists, how do we align and where does OS-CMR fit? And so, are we in the realm of, CT coronary angiogram, coronary artery calcium score, with the latest, with all the data coming out, the MESA study and the utility of a negative coronary artery calcium score, what, is OS-CMR something like that? I've heard a really good lecture on that, and what resonated with me was that coronary artery calcium, why it's so powerful is that it gives like I've mentioned before, a snapshot of an individual's lifetime risk of all their risk factors, including non-modifiables like age, gender, sex, and socioeconomic factors. But CT has its limitations. There's risk of radiation as a woman. That's something that I wouldn't want to have, especially of a childbearing age. And so going forward, I think as a community who's all invested in both research and patients at the forefront, I think the only way we can move OS-CMR forward is if we do this collectively. And so I'm super excited to see what's going to come out of this symposium, and how, if there's any champions out there, do reach out, because there's so much momentum going forward, and there's no better time than now.
I couldn't agree more, and I think you raise an important point. What's the clinical role of such a marker? And it's probably something that even in our minds still has to evolve. But to me, certainly it has the potential to serve as a fundamental marker. Microvascular function or vascular function in general will always be one of the first questions, not only for diagnostic decision-making, but also for therapeutic decision-making, for following up patients for risk stratification. So there are a lot of, and it's not one Swiss knife for everything, but it is, to me, an essential component of every assessment of a cardiovascular patient. And be it as part of a cardiomyopathy, be it as part of heart failure, or coronary artery disease. So I think information on microvascular function, and we do not have any other tool that comes even close into that area. And you mentioned coronary calcium. I think coronary calcium is a good overall marker, but recent data have shown that coronary calcium is even more frequent in people with a healthy lifestyle, and if they are athletes, so basically non-competitive athletes or veteran athletes, they even have a higher coronary calcium. But we know already that these people actually tend to live longer. So coronary calcium alone also will have to seen differentially. If this is a patient with otherwise risk profile, that means probably something different than in someone who's a veteran athlete and who had perivascular inflammation. That not necessarily means that the endothelium is prone to future events. So there's a lot of interesting stuff coming, and so we hope that others will jump on that and will start research. As I said, we will definitely help. For tomorrow, I want to point out, as Judy already mentioned, so tomorrow we will get rather practical. So at 10 o'clock, we will start with a live demo of how B-MORE scan is acquired. So we will have a volunteer in the scanner and be there basically in real time, go through the procedure, and then we will look at the data with the TOM, the tissue oxygenation module, with the help of Mitchel, and then go through cases with Liz and Judy, and we'll discuss the clinical applications and also the limitations. Let's face it, there are some challenges to this method, and we have to make sure that we detect them and address them, so that as any diagnostic tool, nothing in medicine is absolutely perfect, but this is where we will have to use the opportunity tomorrow to discuss. And then we will have an open discussion about what, basically continuing our discussion right now, what could be future applications of BMO, what are important next steps in terms of the clinical validation, in order to make this more available and eventually add it to a standard CMR scan. So thanks to the discipline of all the speakers, we will then end a few minutes before time. So that gives those here a chance to still get to lunch a bit early, and others to their dinners. And to those calling from Asia, thank you very much for the effort on your end to do that at an inconvenient time. And I hope to see most of you, and ideally all of you, back then tomorrow morning. So with that, from my point of view, I say goodbye and thank you very much to all the speakers. They were fantastic talks, and also for all the attendees and for their contributions, not only by their presence, but also by questions and comments. So Judy, any last remarks? Otherwise we can adjourn then, yeah.
Yeah, I just want to again reiterate that tomorrow it's more of an open session. So we'd like to see your faces if you can. Don't have to put any makeup on. It's going to be a Saturday evening for most, but we'd like to see your faces, and we want to make it as interactive and open as we can tomorrow. So much a different format for tomorrow. Feel free to unmute your mics, and if you have any questions, just feel free to raise your hand. And so we want to be able to see you and hear you and interact with you tomorrow.
Okay. Thank you very much, and then we'll hopefully see you then. Okay, bye-bye.